So good morning all of you to all the PG aspirants, and today we are going to have a detailed discussion of all the obstetrics gynecology questions in the recent INI-CET exam which was held in July 2021. Okay, so we will take a question and we will study the aspects of the question as to why this question was asked, what are you supposed to know about this question, and also what are you supposed to know on this particular topic. So that is the way we have to like retrograde see all these questions. So we'll go directly into the questions. Question number 1, HCG is structurally and functionally similar to. Now this is such a basic question. This is a question on human chorionic gonodotrophin. So you all know that human chorionic gonodotrophin is secreted by the syncytiotrophoblast. And let us discuss the basic properties of human chorionic gonodotrophin. This is a very important topic. All the basic points. Now, HCG is basically a glycoprotein. What type of a hormone is it? It is a glycoprotein. Is that okay? It's not a polypeptide. It's a glycoprotein. And here the most important point is, now this is the hormone in the human body with the highest carbohydrate content. So please understand, now this is the hormone in the human body with the highest carbohydrate content. So nearly 30% of human chorionic gonadotrophin is carbohydrate. Nearly 30% of human chorionic gonadotrophin is carbohydrate. Hence we also have this hormone described as the sweetest hormone. We also describe this hormone as the sweetest hormone. Is that okay? Fine. Now, the point to remember here is, this HCG actually has an alpha component and a beta component. While the beta component is specific for HCG, so please understand, beta component is specific for HCG, this alpha component is not. This alpha component is similar to the other hormones like, say, follicular stimulating hormone FSH, luteinizing hormone LH, and thyroid stimulating hormone, that is TSH. So let's analyze this. Now let's analyze this. Fine. Okay. So suppose say we have a condition where HCG is in excess. So HCG is naturally increased in pregnancy, and we have a condition, say for example a molar pregnancy. So we have molar pregnancy, and what happens in molar pregnancy? The level of HCG is very, very high. You all know this. Yes, it's very high compared to a normal pregnancy. So now in this pregnancy, she develops thyrotoxicosis, features of thyrotoxicosis. And when asked why, your answer is, that is because of TSH-like activity. TSH-like activity of HCG. What HCG? Alpha HCG. Is that understandable? Fine. Number 2 point. Now she also has a few cysts developing in the ovary which are called theca lutein cysts. Why are these cysts due to? These cysts are because of the fact that the ovary is getting hyperstimulated. Why ovary is getting hyperstimulated? That is because of FSH-like action. And also LH-like action. Also remember the fact that HCG injections can be given as ovulation trigger. So what do you mean by ovulation trigger? Suppose we have a patient with infertility for whom we are doing ovulation induction. Now when the oocyte reaches a size of about say 18 to 20 mm, we have to make that follicle to rupture. So when the graphene follicle reaches a size of 18 to 20 mm, in order to make the graphene follicle rupture, we have to give a ovulation trigger. So generally what injections do we prefer in practice for this ovulation trigger is injection HCG. Why? That is because of injection LH action of HCG. Is that okay? Now let's go back and look at this question now. Is structurally and functionally similar to, of course, FSH, yes, it's right. Of course, LH, right. Of course, TSH, yes, but not oxytocin. But the question here is, because this is a single best answer question, you have to choose a single best answer. Maximum similarity to which of these three hormones? The answer is LH. So please understand, though HCG alpha component resembles FSH, LH and TSH, maximum resemblance of alpha HCG is to luteinizing hormone. I hope you understand. Okay. So the question can be modified in a different way. HCG is structurally and functionally similar to all of the following hormones except. So when you are given a question like that, HCG is structurally and functionally similar to all of the following hormones except, then your answer will be oxytocin. Okay. And for this question, structurally and functionally similar to which of the following FSH, LH and TSH, you are going to write LH. And please do remember, it is also similar to FSH. It's also similar to TSH. Fine. Okay. The other points about HCG that can be asked in further exams is that you should know that HCG has a very unique concept, that is doubling. Okay. So when we take the levels of HCG, supposing we take the level of HCG, HCG has a very unique doubling concept, doubling of HCG, the doubling effect of the hormone. It is actually said when the pregnancy is intrauterine and when the pregnancy is viable. So please remember, it's a viable pregnancy. I mean, it's a live embryo inside. It's not a failed pregnancy. And intrauterine pregnancy, which I am writing as IU. I am not talking of ectopic, please remember. So in case of a viable intrauterine pregnancy, HCG values will start to double and reach a peak at 10 weeks. And reach a peak at how many weeks? 10 weeks. So that can be written as 70 days. So this is one very important question in the exam. Peak HCG level in pregnancy is seen at how many weeks of gestation? You can say it is 10 weeks of gestation, that is 70 days. Okay. Now this doubling is seen where? In a viable intrauterine pregnancy. Though we commonly call doubling, actual description is that there is a 66% rise in the value of HCG. 66% rise in HCG values every 48 hours. So when asked doubling time, you can say the doubling time is 48 hours. And it's not exactly doubling. 50 becomes 100, 100 becomes 200. No, it is 66% doubling. So if today's value is 100, then after 48 hours, it is 66% of 100 is 66. So after 48 hours, it is 166. Is that understandable? So it is 66% rise in HCG values every 48 hours. Okay, so this concept you should remember. Now this doubling is absent in case of a non-viable pregnancy and also in ectopic pregnancy. So doubling absent when it will not double, when you will not see a 66% rise in 48 hours in a case of a failed intrauterine gestation. In case of a failed intrauterine gestation, not only in failed intrauterine gestation, also in ectopic pregnancy. Is that right? Fine. So I am happy that I have told you this point. So here also please remember the peak value because it's a very important question. So after 10 weeks, the value of HCG almost remains constant, static throughout the rest of the pregnancy. There's a slight secondary peak at 32 weeks, which is insignificant. We are not worried about that. But the point for us is, when does HCG come back to the pre-pregnant value? I mean, undeductible levels. It's not a normally present hormone. You know, it's produced only by the sensitive trophoblast. So when does it come to undeductible levels after delivery? It comes to undeductible levels after 2 weeks. So this is another very important question in the exam, which you might expect. Okay. So please remember that HCG becomes undeductible after delivery in how many weeks time? In 2 weeks. So is that understandable? Okay. Now let's talk just about the values of HCG. Sorry. Now let's talk about the values of HCG, which we are going to talk. I told you that the values are increased, and when compared to normal values in a pregnancy, when are the values increased and when are the values decreased? The HCG levels are higher in multiple pregnancy when compared to a singleton. And HCG values or increased in case of molar pregnancy. You all know that it is increased in molar pregnancy. And also remember that the first trimester values and the second trimester values of HCG, if the baby is a baby of Down syndrome, the values are slightly higher when compared to the normal, that is trisomy 21. I'll talk about this in detail in future now. So HCG values are lesser in ectopic gestation. You know why? Because there is no doubling. Also in failed intrauterine gestation. Also in failed intrauterine gestation. So please make a note of it when HCG values are higher and when HCG values are lower. Now let's talk about the most commonly asked triple test and quadruple test. You do have a question on triple test and quadruple test in the INI-CET July 2021 paper itself. So we'll discuss it and then we'll see the question next. Fine. So what is triple test and quadruple test? I commonly advise students to follow very small mnemonic AB3. Fine. Now this is a very simple way of remembering. Even in the middle of exams, if you get confused, see ABC, remember ABC, instead of writing the third alphabet, you are going to write the third number, that is AB3. Is that okay? Now this is very simple. For A, you are going to write alpha fetoprotein. Please remember. For B, you are going to write beta HCG. Of course, you are going to use only that beta HCG which is specific, right? Okay, we are not going to talk about alpha HCG in any of our diagnostic tests because it does have similarity to FSH, LH and TSH, you know that. And when coming to this 3, I write here 3 because we are talking about unconjugated estriol. Unconjugated estriol, UE3. So we'll make a line here. So when we talk about estrogen, please do remember we have E1 which is estrone and we have E2 which is estradiol, and we also have E3 which is estriol. Is that okay? Now, estriol is the main estrogen which is produced in pregnancy. So, whenever we are going to do any diagnostic test concerning estrogen levels in pregnancy, we are going to talk about only E3. I hope you understand. So, most of the times the questions come here like which of the following true or false. Instead of estriol, they'll give you estradiol here and try to confuse you. So, please make a note of this, and this you will not forget if you remember AB3. Is that okay? And estrone is the most common estrogen in postmenopausal women. Menopausal, and estrone is produced by the peripheral conversion of androstenedione. Androstenedione is getting converted to estrone. And estradiol is the most potent estrogen. You know, estradiol is the most potent and it is produced in reproductive life. And in pregnancy, placental production, you have estriol. Is that okay? Now, please remember, only beta, it's a pregnancy, so what is high? Beta HCG. Now beta HCG is high. I hope you are able to understand the fact. So now we are going to study about triple and quadruple test for Down syndrome, that is for trisomy 21. Is that okay? So for trisomy 21 we are going to study, or let me write it here so that you have a clear understanding. So we are studying for trisomy 21. And please understand, only this beta HCG is high. Only this beta HCG is high. That means the other two are low. Or you can remember B for big, therefore beta HCG is high. And for quadruple test, please remember the component in quadruple test is inhibin. Okay, the component in quadruple test is inhibin A. And this is the question that is asked in this AIMS exam, whether this is A or B, and we use only inhibin A. Is that okay? And inhibin A also you can remember I for increased. Inhibin A also you can remember I for increased. I for increased. So this is a very simple way of remembering B big, I increased. All the others are decreased. All the others are decreased. You also have a dual marker. You also have a dual marker for Down syndrome, which is done in the first trimester, which is just alpha fetoprotein and Pap A. Alpha fetoprotein and Pap A. Of course, now tell me, sorry, this is beta HCG and Pap A. Now you can tell me this is beta HCG and Pap A. Now you can easily tell me what is high, what is low. B for big, it is increased, and Pap A, of course, it should be low. Or you can take P for paucity, that's not needed. Please remember B for big, so beta HCG is more, I for increase, so inhibin is more. All the other things are decreased in Down syndrome. Now is that very, very clear? Okay, so that is it. It is very simple. Okay, now let us also discuss the hormonal profiles in trisomy 18, which is Edwards syndrome, and trisomy 13, which is Patau syndrome. Please understand, trisomy 18, everything is decreased. We are not talking about inhibin A here. We are talking only about the triple test. So here all are decreased. So please remember, trisomy 18, all are decreased. Fine. And trisomy 13, when you remember trisomy 13, please remember that, and also please remember always this estriol in all the trisomies it is less. All the trisomies it is less. So remember this point, estriol in all the trisomies it is less. Trisomy 13 is exactly opposite to trisomy 21. So you find that alpha fetoprotein is high and beta HCG is same, no change or decreased. Okay, so mostly these two might not come in exams, though it's very easy to remember. Okay, you start with writing AB3, alpha fetoprotein, beta HCG and unconjugated estriol, also inhibin A for the quadruple test. Simple, very simple. And when asked what is decreased and what is increased, remember we are dealing with trisomy 21, beta HCG big increased, inhibin A, I for increased. All the others are decreased. And when it is trisomy 18, in the triple test, we don't take inhibin into account. In the triple test, everything is decreased for trisomy 18. When you take trisomy 13, again remember unconjugated estriol is decreased for all, so it is decreased for trisomy 13 also. The other two will be the opposite of what you have studied for trisomy 21. So please remember this table, and this might definitely come in exams. So many a times we have had questions on this triple test and quadruple test. Either what are the components or what is increased, what is decreased. Okay, so please make a note of this. Okay, so that's as simple as that. And look at the second question now. All of the following are components of quadruple marker test except. So when we talk about quadruple marker, it is A, B3, alpha fetoprotein, B for beta HCG, 3 for unconjugated estriol, plus inhibin. So what inhibin are we were talking? Inhibin A. Is that right? Now when we are marking for Down syndrome, how are we supposed to mark? Beta HCG high, inhibin high. The other two low. So maybe I will not mark. Okay, that's it. So here they have just asked only the components. They have not asked which is increased and which is decreased. Okay, so here the answer is inhibin B. And conjugated estriol. So many a times they will try giving this as estradiol, or they will try to give it as estrone, and they will try to confuse you. Is that okay? Now this is correct, this is correct, this is correct. Though this has to be specifically what? Beta HCG. I hope you are able to understand. Okay. So please keep all these points in your mind. So a very simple question, only HCG. If you have read this topic and details about HCG, which you cannot miss, miss for the exams, you can definitely answer 2 questions. Is that okay? Okay. All these are very simple and very direct questions. So now let's talk about question number 3. This is uterocervical length in adult woman. So what is the uterocervical length? So let's talk about the dimensions of almost all the organs, female genital organs. Okay. Now this is the cervix, and this is the anterior vaginal wall. Now this is the posterior vaginal wall. And we know the anterior vaginal wall is related to what? The anterior vaginal wall is related to the urethra and the bladder. Is that okay? And we also know that the posterior vaginal wall, it is related to the rectum, okay, which I am not going to draw. And now can you see that the anterior, when compared to the anterior vaginal wall, the posterior vaginal wall is attached at a higher point on the cervix. So the posterior vaginal wall is longer than the anterior vaginal wall. Now when we talk of the length of anterior vaginal wall is 7 centimeters. The length of posterior vaginal wall is 9 centimeters. Please make a note of it, can come in exams. Okay. Okay. Now let's go with the cervix. Now when we take this, the length of the cervix, when we take this, the length of the cervix, it is 2.5 centimeters. It's a range actually from 2.5 to 4. But when we want to write a single number, we will write 2.5 centimeters. Is that okay? Now let me finish off this. Okay, fine. So we'll stop with this. Now when we are talking about the dimension of the uterus, so please remember we are going to talk about the dimension of the uterocervical canal as such, which is commonly written as 3 into 2 into 1 inch. So this way of talking in inches is just to make you remember it easily. That's it, nothing else. Okay, remember. Now let's convert it into centimeters. So it is, how do we convert inches to centimeters? We just have to multiply by 2.5. So when we multiply by 2.5, now it is 7.5 centimeters. So this is in centimeters, into 5 centimeters into 2.5 centimeters. So actually the 7.5 refers to what? The length. 5 centimeters refers to what? The breadth. And 2.5 centimeters refers to what? The thickness. Is that understandable? The length, breadth and the thickness. Now let's take the 7.5. Actually it is not 7.5, it is 8. So please remember, when we talk about dimension of the uterus, if I am going to tell you directly it is 8 into 5 into 2.5, you will not remember it. Therefore, we say 3 into 2 into 1 inches and convert it into centimeters and make that 7.5 into 8. So many books approximate that 7.5 as 7. We are not to read. I'll talk to you about the exact dimensions. Okay. So it is 8. So 8 into 5 into 2.5. So what is this 8? So let's mark. Please follow carefully. Now let me take this. So 8 is starting from the fundus up to the external os. Starting, that is the uterocervical length. Now this is 8 centimeters. So what is 8 centimeters? 8 centimeters is starting from the fundus to the external os. It is 8 centimeters. Is that okay? Fine. Now here we also have this isthmus, which is 0.5 centimeters. Isthmus is a region between the anatomical internal os and histological internal os. Okay, we are not going to in detail. This isthmus becomes a lower uterine segment in pregnancy and we make our cesarean incision on the lower uterine segment. I hope all of you understand this. So now take cervix and isthmus together will be 3 centimeters. So the remaining 5 centimeters we have. I hope you are able to understand. Remaining 5 centimeters we have, and that is from the fundus up to the internal os. So now this black line is 5 centimeters. And please understand that there is no cavity in the fundus. There is no cavity in the fundus. This fundus is a thick muscular wall. Now this is 1.5 centimeters and the cavity only is 3.5 centimeters. So any number from this can come in the exam. I'll list all the questions now. Come on, we'll finish this. Starting from the fundus up to the external os is 8 centimeters. We have the cervix which is 2.5 centimeters and the isthmus is 0.5 centimeters. So this together is 3. So 8 minus 3 is 5. So from the fundus up to the internal os is 5 centimeters, of which, so from in the 5, we have 1.5 centimeters is a fundus and 3.5 centimeters is a cavity. I had seen a question in the recent exams asking what is the length of the uterine cavity only. Please understand, the length of the uterine cavity only, it is 3.5 centimeters. So you can expect this question also in the exam. Is that okay? Now we have done with this. And what is this 5, which is the breadth? Maximum breadth. So what is the maximum breadth? Please understand that the maximum breadth is the intercornual distance. The maximum breadth is the intercornual distance, which is 5 centimeters. So sometimes you can have questions in the exam like, what is the intercornual distance, which is 5 centimeters. So let me list the questions here based on the length. Fine. And you all know what is the length of female urethra? It is 4 centimeters. So what is the length of female urethra? What is the length of anterior vaginal wall? 7 centimeters. What is the length of posterior vaginal wall? 9 centimeters. What is the length of the cervix? You say 2.5 centimeters. What is the length of the isthmus? It is 0.5 centimeters. What is the length from the fundus up to the external os? Now you say it is 8 centimeters. Fine. So what is the length from the fundus up to the internal os only? Then you say it is 5 centimeters. Now what is the length of the uterine cavity? What is the length of the uterine cavity only? You say it is 3.5 centimeters. Now what is the intercornual distance? So the intercornual distance is 5 centimeters. I hope you have got all these dimensions correct if you remember this simple picture. Is that okay? Now I haven't talked about the tubes. Now we will deal that later. So please remember this. Come on. So the question, the uterocervical length, it is 8. But what answer is close to 8? We have 7. So let's choose this answer, that is 7 centimeters. Is that okay? So I hope you are all able to understand up to this. Okay. So if you want me to talk about the tubes, we know that the first medial most part of the tube is the interstitium. The medial most part of the tube is the interstitium. Now this is a very thick segment. After the interstitium, you have the isthmus. Isthmus. So from medial to lateral I am talking. Then you have the widest and the largest and the widest portion of the tube, which is the ampulla. Is that right? So again, lateral to the ampulla, now you have infundibulum. Then we have the fimbria. And you all know, in the fimbria, one of the fimbria will be longer when compared to the rest. Okay. Now when we talk about the total length, let's leave off the fimbria and talk. Now it is 10 centimeters. It is 10 centimeters. If you want me to mark the individual length, it's very simple to remember. Start with 1.25. So interstitium is 1.25. Double 1.25 for isthmus. Isthmus is 2.5 centimeters. Ampulla is 5 centimeters. And infundibulum is another, come back to again 1.25. Now when you add all this, it comes to 10. Here also, individually, they might ask you the length of each of the segments, or they might simply ask you which is the longest portion, ampulla. Which is the widest part of the tube, ampulla. Which is the narrowest part of the tube, it is interstitium. Is that okay? So they might ask you questions like this. So remember the dimensions and all the numbers. So I think we'll go to the fourth question. Now this is very interesting. This is very interesting in that we have 3 questions only on Pap smear. We'll see all the 3 questions. What procedure is done with the help of the instrument shown below? So what do we have here? We have the Cusco's speculum. You all know Cusco's speculum. Now this is a self-retaining speculum and it is used to depress the posterior vaginal wall. Of course, give a very clear visualization of the cervix. And the advantage of this is it is self-retaining. You will not need an assistant to hold the speculum. Whereas a sim speculum, you will need an assistant to hold the speculum. And sim speculum, you will have to give one posterior vaginal wall speculum and anterior vaginal wall speculum to visualize the cervix properly. But here it's not needed. Okay. Now we do have a glass slide. Okay. And this is the Ayer spatula. This spatula is the Ayer spatula. And please look at the Ayer spatula carefully. Like it's a very small wooden stick. And when you carefully look at the Ayer spatula, one end you see a small, one end is, in both the ends, you see one end here is elongated. And here see how it is designed. And why the 2 ends are different like this, you must know. That is because we are going to use this to take a Pap smear from the cervix. Okay, and of course all of you know that the cervical os, the shape of the external cervical os is different in nulliparous woman and multiparous woman. Okay, I'll show you pictures of them and which end is used for what, I'll show you. And here we also have a endocervical brush. So this is a brush to collect the material from the endocervix. So this is endocervical brush. So basically what are we going to do? We are going to take a Pap smear. So very simple and very common procedure in the OPD. So we are going to do a Pap smear. Fine. So what are the steps in the Pap smear? We do have a question on the steps in the Pap smear. So first I'm going to put in the Cusco's speculum, introduce the Cusco's speculum, visualize the cervix and visualize the cervix for any growth, ulcers, polyps, any abnormality in the cervix. Okay. Now, and then what we do is no lubricants, no using xylocaine jelly. Fine. They'll all alter the cytology. That's very, very important. If there is a profuse vaginal discharge, then we are not going to do a Pap smear. We're going to treat the discharge and then only we are going to do a Pap smear. Is that okay? Now, let's all look at the shape of the cervical os. Now, this is a pinhole os. In a woman and nulliparous woman. Now, we cannot say nulliparous. A woman who never had a vaginal delivery. Maybe we can now refine our statement like, if this woman never had a vaginal delivery, her cervix, she's definitely not going to have cervical tears during the process of labor. So definitely the osses are going to remain pinhole. Okay. So this woman has not had a delivery at all, or she has not had a vaginal delivery, meaning she might have had a cesarean section. So nulliparous os. And you see now this is a multiparous os or a woman who had a vaginal delivery. And what is the shape? Now it is a transverse slit. It is a transverse slit. Is that okay? Now look at the Ayer spatula carefully. Now please look at the Ayer spatula carefully. This end of the Ayer spatula is used to take a smear from the pinhole os. It is used to take a smear from the pinhole os. You see how correctly it will fit in. Now this end of the ear spatula is used to take a pap smear from os which is like a transverse slit, and here also you find one end will be slightly longer than the other, which the longer one will go into the cervical os, and then you make a 360-degree rotation. So step number 1, we put in the cusco-speculum. Step number 2, visualize the cervix properly. Step number 3, take the ear spatula, identify which end of the ear spatula you are going to use depending upon what type of the cervical os it is, and then you put that end on the cervix into the os. You make a complete 360-degree rotation and do a scraping of the entire transformation zone. We are not going to scrape the ectocervix. We say what? Transformation zone, about which I'll be talking later. So we take a smear. So what happens now? Cells will stick on to from the transformation zone. We find that cells will stick on to the ear spatula. Now we are going to smear it on the glass slide. And so when we smear it on the glass slide, what happens? Now the cells will stick on to the glass slide. And then finally what we do, we can either spray alcohol. What alcohol we use? Usually we use a combination of 95% ethyl alcohol. Okay, so 95% ethyl alcohol we usually spray and air dry and put it into a jar and send it to the lab. Or conversely, you can put it into a Copland's jar. You have all seen Copland's jar in your OPD. You can put it in the Copland's jar which has alcohol. So directly smear and put it into the Copland's jar. Also make a note, don't smear twice or thrice. When you smear twice or thrice, the point is you will have cells overlapping one another. Then your sensitivity of the pap smear is going to decrease. Okay, so please understand the steps of a pap smear, which is also a question in the exam. Okay. You can use another slide to take a smear from the endocervix and with the brush, and you can smear it to another glass slide. Label it properly. Like one slide is from the transformation zone. I have collected cells from using an ear spatula. The slide number 2, we have collected cells from the endocervix using this brush. You can label them separately and then you can send it to the pathologist. Okay, so which of the following is used as a fixator for pap smear? The answer here given are methyl alcohol, 95% ethyl alcohol, air dry, 10% neutralized formalin. The best answer is 95% ethyl alcohol. Okay, so see how simple question, and you have 3 questions. Okay, we'll finish up this question and I'll talk to you about the inference of what we have learned so far. Which one of the following is the correct step in which pap smear is taken? So what are we going to do first? We are going to place a vaginal wall retractor. So A will be first. Then we are going to scrape the ectocervix. Yes. And then what I'm going to do? I'm going to prepare the smear. I'm going to smear it. Yes. And then we are going to fix it by using a fixator, which is ethyl alcohol. So A, C, D, B. So this is our answer. Very simple. So now we will talk about the inference. Please understand that in the recent system of exams, you are supposed to know the common gynecological procedures done in the OPD also in your theatre. Is that okay? So the very basic exam does not test whether you know about liquid-based cytology, whether you know the sensitivity, whether you know the pap smear screening protocols. They are testing whether you have yourself done a pap smear in the OPD. Those students who have watched the procedure or have done a pap smear themselves, who have fixed it, who have labeled it, who have sent to the lab, will very easily answer this question. Is that okay? So from this inference, we can expect questions on what are the other common drugs used in obstetrics and gynecology, common management of all the obstetric emergencies like PPH. You will have to know about oxytocin, methergine, prostadine, tranexamic acid, misoprostol tablets. Is that okay? You also have to know about the common procedures. Okay, so how do you manage eclampsia? You have to know the Maxwell's regimen. You have to know episiotomy. So definitely they'll ask you what are the structures cut during episiotomy, what are the instruments used for episiotomy, what is the difference between medial-lateral episiotomy. This discussion is basically meant to, like, from one question, you analyze that question, you should also be able to predict from what all topics the other questions will come. Okay, you should be able to know about inversion uterus, which you can see in the in the obstetric in your labor wards. Okay, you also have to know how a oxytocin drip is given. A very simple questions on oxytocin can come in the exam. Okay, so please orient yourself to all the common procedures that are done in the obstetric OPD, gynec OPD, also in the obstetric and the gynec theatres, also in your labor rooms. Okay. Now, additional point on this, I wanted to talk to you about transformation zone, because this is a point which you have to understand and may be asked in future exams, and we can predict this. We all know we have ectocervix and endocervix, right? So now this is ectocervix, and then we have the endocervix. A very simple picture I'll draw. What is the epithelium of ectocervix? So simple questions like this can come in the exams. What is the epithelium of ectocervix? Now it is stratified squamous epithelium. What is the epithelium of the endocervix? It is columnar epithelium. Is that okay? Okay. So what junction we have? We have the squamo-columnar junction. Now let me mark it as original squamo-columnar junction, that is which is before puberty. So before puberty, a girl has only one squamo-columnar junction. Okay. Now what happens during puberty? Vaginal pH becomes acidic. After puberty, vaginal pH becomes acidic. There is also a slight opening of the cervix, which we call slight eversion of the cervix. So what happens is this columnar epithelium gets exposed to the acidic pH of vagina. I repeat, the columnar epithelium gets exposed to the acidic pH of vagina, wherein this epithelium will not be able to tolerate. So it gets metaplasia, converted into squamous epithelium. Is that okay? So columnar becomes squamous. So what happens from the basal layer? Columnar comes and columnar gets converted into squamous. So we simply say squamous metaplasia. Now this is metaplasia. Columnar becomes squamous. And with the establishment, now with this change, now we have a new squamo-columnar junction. We have, which is inside. Okay, so you can also remember old squamo-columnar junction or original squamo-columnar junction is outside. Everything starts with O. And the new squamo-columnar junction is inside, or you say this is the upper limit. Yes, this is the upper limit. So new squamo-columnar junction is inside. Okay, now the region between the old and the new squamo-columnar junction, that is this region. Okay, now this region is the transformation zone. Okay, so that's it. So definitely you can expect questions in the exam based on the transformation zone. Again, a small depiction. See, the yellow ones are the squamous and the blue ones are the columnar. This is the squamo-columnar junction, the original squamo-columnar junction before puberty. Okay, so what happens now? Now this is the original squamo-columnar junction. Now because of the eversion of the cervix, some columnar epithelium has come out and got exposed to the acidic pH of vagina, and now these columnar epithelium are getting converted into squamous epithelium. Now therefore this zone, these cells, now this zone is a transformation zone. So what are the cells actually now in the transformation zone? It is squamous. From where they have come from columnar. Okay, so now this is a picture question which I saw in a very recent exam. Like now when you mark, please understand, like this is the old squamo-columnar junction. This is the new squamo-columnar junction. This dull pink color which you see they have written as metaplastic squamous epithelium. They have written as transformation zone. So this dull pink color is actually the transformation zone. Of course, in this transformation zone, you are able to visualize the old squamo-columnar junction, which will always be outside. I told you, old will be outside. The new squamo-columnar junction is also visualized. So this is a transformation zone where the entire extent of the transformation zone is visible. I hope you are able to understand. Now let's go into the colposcopic classification of transformation zone. See, all these are latest and all these are very, very important. So what picture I have shown you is a type 1 transformation zone where the whole transformation zone, including the upper limit, is ectocervical, means it is seen outside. It is not inside the cervix. Okay, now this is a type 1 transformation zone. So this is the upper limit. What is the upper limit? The new squamo-columnar junction is the upper limit. It is also seen outside. What is type 2? The upper limit of the transformation zone is inside the endocervix. Now it is inside the endocervix, but we can see it. At least by small retraction, we can see it. But type 3, the upper limit of the transformation zone is deep inside the endocervix and we will not be able to see it. Okay, so in the exams, we do expect questions Very simple, like what type of transformation zone it is. So can you tell me what type of transformation zone it is? Now this is the, now this is the old squamocolumnar junction or the original squamocolumnar junction. Okay, so let me draw it. Yes, and now this is the new squamocolumnar junction. The dark red color is actually the endocervix which has come out and it is slightly seen. Okay, now this is a new squamocolumnar junction. And this region between the old and the new squamocolumnar junction is the transformation zone. The entire transformation zone is seen and visible on the ectocervix itself. So it is what type of a transformation zone? It is type 1 transformation zone. So please, since we have 3 questions on Pap smear, I wanted to talk to you about transformation zone, the colposcopic classification of the transformation zone. Is that okay? So that is all about the Pap smear, a very important topic. We have 3 questions. Fine. So this also says that sometimes we have multiple questions from the same topic. When you analyze this INI-CET July paper, we don't even have a single question on contraception. Fine, we don't have a single question on contraception. But sometimes you might have a question paper fully loaded with questions on contraception, say 4 or 5 questions. So the inference from this is all the topics should be given importance. Never like leave off the whole topic and go. Then if you have 4 or 5 questions from that topic, you will lag behind. Is that okay? Okay. Which of the following represents a symptom for endometriosis? And you all know what is endometriosis. What is endometriosis? Endometriosis is the presence of endocervical glands, endocervical epithelium. So epithelium includes glands, yes, plus stroma at ectopic sites, anywhere outside the endometrial cavity of the uterus. Okay, anywhere outside the endometrial cavity of the uterus. So if we have endometrium in the ovary, then it is endometriosis. Okay, so when we talk about the most common sites, the first most common site of endometriosis is ovary and sites. The second most common site of endometriosis is the pouch of Douglas. Okay, third most common site of endometriosis is the broad ligament. Okay, and the basic point about endometriosis is that it is equally responsive to estrogen and progesterone like intrauterine epithelium. It is equally responsive to estrogen and progesterone like intrauterine epithelium. So what happens for the first 14 days of the cycle? There is proliferation. For the remaining 14 days of the cycle, there is decidualization. And then when there is menstruation, there is bleeding. So bleeding can collect in the form of a cyst, and the altered blood becomes the so-called chocolate cyst. And I hope you all know this pathology. So what are the symptoms here? The symptoms are, number 1 is pain. What type of pain? It is dysmenorrhea. Dysmenorrhea. What type of dysmenorrhea is it? It is usually triple dysmenorrhea. There is pain before periods, there is pain during periods, and pain after periods, which is called triple dysmenorrhea. Very classical of endometriosis. Number 2 is dysperonia. She has dysperonia because of the endometriotic spots in the pouch of Douglas. Okay, so dysperonia. Number 3, dyskesia. Dyskesia is that she has, because of the implants, endometriotic implants in the pouch of Douglas, she has difficulty in defecation and pain during defecation. That is dyskesia. Okay. Also remember dysfertility. Infertility. Why infertility? There are multiple reasons. The chocolate cyst can interfere with ovulation. The oocyte may get caught in the adhesions. There are multiple reasons. And also DUB. DUB means there are menstrual abnormalities. So now let's go back and look at this question. So endometriosis is usually called as disease of 5 Ds. Dysmenorrhea, dysperonia, dyskesia, dysfertility, infertility. Which we wanted to include here. So we write dysfertility and menstrual cycle abnormalities, usually menorrhagia. Now, the question is a bit tricky. The question asks only 2. Of course, not vaginal discharge. We'll strike this off. Infertility is there, dysmenorrhea is there, menstrual disturbances is there. But if we want to select only 2, then we always go for infertility and dysmenorrhea. So most common complaints most common complaint in a woman who presents to the OPD, she is anxious to conceive and she also complains of dysmenorrhea. It's even more common than dysperonia and dyschezia. So if you have to select two, you have to select infertility and dysmenorrhea. So A and B will be the answer. So the inference from this question is, how many cases of endometriosis have you seen in your OPD, and for how many patients have you elicited the symptoms? So patients usually will present to your infertility OPD. So very important, people with endometriosis present to the infertility OPD. And the most common symptom when you ask, rather than complaining of menstrual disturbances, they will usually complain of painful menstrual cycles, that is dysmenorrhea. So you have the knowledge of most commonly infertility and dysmenorrhea, and that is needed to answer this question. Even if you have read all the 5 Ds in order, you will not be able to answer this question. Only if you have seen an endometriosis patient in your infertility OPD and elicited history for yourself, then this question becomes a very simple question. Okay. So the 8th question goes like this. To call the semen analysis as normal, what should be the least percent of morphologically normal sperm? So before we go and answer this question, let's talk about semen analysis in detail. So now we are going to talk about 2010 WHO semen analysis characters. And this is usually the first investigation to be done when we investigate an infertile couple. You all know that. It's the first investigation. Should be done ideally after 3 days of abstinence. Fine. And the sample has to be examined within an hour, and the transportation to the lab, it has to be done at an appropriate temperature. So all these are important. Now, when we talk about the semen analysis parameters, first let us talk about the volume. Okay. So what should be the normal volume? Volume is less if it's less than 1.5 ml. So equal to 1.5 or more than 1.5 is normal. Okay. So I'm just writing what are all abnormal. Okay. Abnormal. And when we talk about the count, when the count is less than 15 million per ml, when the count is less than 15 million per ml, we say that the count is low, and we call it as oligospermia or oligozoospermia. Both are same. Is it okay? So that is about the count. Now let's talk about the motility. Motility. Please understand that there are 4 types of motility, which we usually write as A, B, C, D. A, B, C, D. A is rapid progressive. A is rapid progressive. I mean the spermatozoa move very fast and rapid. B is slow progressive. B is slow progressive. C, it's motile, but it is non-progressive. I mean, it's motile at the same point. It's not going to go forward. It's motile at the same point, non-progressive. And D is immotile sperms. Okay, so you basically divide it like this. When we are talking of progressive motility, so I'll write it as, when we are talking of progressive motility, the progressive motility should be greater than 32%. So if it is less than 32%, then the motility is abnormal. When we talk about progressive plus non-progressive, progressive plus non-progressive, it should be more than 40%. So when it is less than 40%, then we say the motility is less, in which case we call it as asthenospermia or asthenozoospermia. Both are same. So progressive motility should be greater than 32%. Is that okay? That's it. Okay. Now let's talk about the live sperms. Live sperms. The amount of live sperm should be more than 58%. So when it is less than 58%, we say that we call it as necrospermia. We call it as necrospermia. Necrospermia. So please remember all these numbers. We'll come to morphology. The sperms with normal morphology. I hope all of you know the normal morphology. We're not talking about the ones with 2 tail or ones with 2 absent middle piece, ones with 2 head. Okay. So normal morphology should be 4%. If it is less than 4%, we call it as teratospermia. Is that understandable? We call it as teratospermia. And when we talk in a semen sample, the WBCs, the WBC's count should be less than 1 million. If it's more, it can signify infection. Should be less than 1 million. So we are talking of abnormal. So if it is greater than 1 million in the semen sample, then we call it as leukocytospermia, which might signify an infection, epididymoarchitis or prostatitis, or like that. Okay, so here the question that has come is morphology. Morphology, if we have 4% of normal sperms or normal, 4% of sperms are normal in morphology, that is enough for normal fertilization to occur. So that is the inference, and this question was asked. So you can also expect questions from other values. Okay, so let's go and mark. To call semen analysis as normal, what should be the least percentage of morphologically normal sperm? It's 4%. Is that understandable? So please understand this question, a very important question. Practice question, I've given you one practice question. Which one of the following is considered normal with respect to semen analysis? Morphology 30% normal forms? No. Morphology 4% or more showing normal forms? Yes. Now this is a normal semen analysis. Sperm volume of 0.5 ml is less. It should be at least 1.5 ml volume. So that's wrong. Sperm with progressive motility of 32% or more? Yes. The sperms with progressive motility of 32% is definitely a normal semen analysis pattern. Okay. So I think we'll go to question number 9. We'll read the question number 9. We'll analyze this question. We'll go into the subject and come back to the question. Analyze the hormonal profile of a 25-year-old woman presenting with amenorrhea and match. So amenorrhea as such, both primary and secondary amenorrhea are very important topics. You can never miss on these topics. I have never seen any question paper without one question on amenorrhea. I have seen question papers with a question on so many other topics, like we do have questions without anatomy, basics. We have questions without infections in gynecology. We have question papers without contraception, as this is the case this time. We don't have a question on contraception, but never have I seen any question paper without a question on amenorrhea. So please be very careful with this topic. So Asherman syndrome, premature ovarian failure, PCOS, Sheehan syndrome, they've given 4 conditions, and they've asked the values of FSH, LH and estradiol. So before we go into this question, I'll just take 5 minutes of your time and describe the HPOU axis and the hormonal patterns and make this question very easy for you. So we have the pituitary gland, the anterior pituitary and the posterior pituitary. The anterior pituitary secreting growth hormone, thyroid stimulating hormone, FSH, follicle stimulating hormone, luteinizing hormone, adrenocorticotrophic hormone and prolactin. Is that okay? Now follicle stimulating hormone and luteinizing hormone, since they act on the gonad, they are called gonodotrophins. You all know that. And they act on what? They act on the ovary. Okay. Now these act on the ovary and make ovary produce what all hormones? Ovary produces estrogen, progesterone. Of course, estrogen is produced only from androgen. So let me write androgen and other peptides like inhibin, activin, follistatin. We'll write the most important one, which is inhibin. Okay. Now, estrogen and progesterone will act sequentially on the uterus, cause endometrial thickening and decidualization, and the withdrawal of hormones will cause endometrial shedding or bleeding. So we see ovary controls uterus, pituitary controls ovary. Now what controls the pituitary release of FSH and LH is the most important master gland, which is the arcuate nucleus of the hypothalamus. Arcuate nucleus of the hypothalamus. Now this arcuate nucleus of the hypothalamus produces GnRH, gonadotrophin releasing hormone, in a pulsatile fashion. GnRH in a pulsatile fashion. Now, if the GnRH pulsatility is more frequent, it leads to the release of FSH from the anterior pituitary. If it's of increased amplitude, it leads to the production of LH from the anterior pituitary. If the GnRH is non-pulsatile, then it blocks FSH release and LH release. Now, don't you think it's very unique? Now you see this one single master hormone controlling the release and inhibition of 2 different hormones. Don't you think this is so nice? Yes. How does it control? Only based on the pulsatility. So now we see the hypothalamus. Okay, let me mark. Like now we see the hypothalamus. We'll mark this H. Okay, I'm sorry. We'll see the hypothalamus, and then we do have the we do have the pituitary, and then we have the ovary, and then we have the uterus. Now we'll put a box here. H, P, and then we do have O and U. So what are we talking about? HPOU axis, or sometimes when we call it as compartments, we'll mark it as compartment 1, compartment 2, compartment 3, and compartment 4. So that's very simple. They control each other. Hypothalamus controls pituitary release of FSH-LH. Pituitary controls the ovary. Ovary controls the uterus. Now is that very simple? Is that very simple? Okay. Now come on. In all the cases of what happens if there is a problem with compartment number 1? So let me write here. So there is a problem with compartment number 1, which I will write as H. If the pulsatility is altered, now what will happen to FSH and LH? If it's not going to produce it pulsatile, what's going to happen to FSH and LH? The levels are definitely going to decrease. If FSH and LH are going to decrease, what will happen to estrogen level? Definitely it will decrease. That's it. What will happen in compartment number 2? Pituitary. I'll write P, compartment number 2. If the pituitary is not going to produce FSH, LH, what will happen? FSH, LH will decrease. LH will decrease, and your estrogen level also will decrease. In other words, this compartment number 1 and 2 together we can take as H and P. Is that understandable? Now we'll come to compartment number 3. Ovary. Ovary, there are a lot of problems in the ovary. Okay, compartment number 1 problems, example I'll tell you, hypothalamic problems, example we'll have Kallmann syndrome. Pituitary problems, we have lots of syndromes, meningitis, encephalitis. In gynecology obstetrics, especially remember Sheehan syndrome, which is postpartum pituitary necrosis because of a massive postpartum hemorrhage. Now the pituitary goes in for a collapse. The pituitary slowly stops producing all the hormones. Is that understandable? Okay. Now compartment 3, ovary problems. What are problems can be in the ovary? The ovary was removed by a surgery, or it is premature ovarian failure. All the follicles have gone for atresia. There are no follicles maybe because she was exposed to radiotherapy, maybe because she was exposed to chemotherapy, maybe because she had multiple cycles of ovulation induction, maybe she had tuberculosis of the ovary. Okay, maybe she has she's a smoker, and because of smoking all her follicles are gone. Maybe this is hereditary. Okay, so many conditions. The ovary has lost all the follicles. So this ovary cannot produce estrogen and progesterone. So please remember, now there is a difference. Estrogen level declines first. Okay. This is an ovary problem as such. So please remember, because there is no negative feedback, we'll draw a line here. Because there is no negative feedback from the estrogen produced by the ovary, what happens is FSH and LH will be high. So that's it. So this is basically the hormonal profile you see after menopause, in cases of premature ovarian failure, after removal of ovaries, after the ovarian follicles get affected in whatever way it can be. So I hope you understand this difference. Come on. Let's look at compartment number 4, which is uterus. Compartment number 4, there are problems, especially when it is intrauterine adhesions, Asherman syndrome, or uterus itself removed. Now this woman goes in for amenorrhea. Okay, again we are talking about cases of amenorrhea, right? Again this woman goes in for amenorrhea. Now what happens is that this uterus is not related to ovarian, does not control ovarian and pituitary production of hormones. Of course, you understand, it is not the uterus controlling other organs, all the other organs controlling the uterus. So that means all the hormones, FSH, if it's an isolated uterine problem, all the hormones will be normal. So uterine problems of amenorrhea, you can very well mark it as Asherman syndrome. A simple understanding of the hypothalamus pituitary ovarian axis is you will be able to answer the questions very easily. Is that right? Now let's go back and look at the questions. Okay, Asherman syndrome is compartment 4 problem or uterine problem where you have all the hormones normal levels. So what will be your answer? FSH normal, LH normal, estradiol normal. Premature ovarian failure is compartment number 3 or ovary problem. So what will happen? Estradiol will be low. Because there is no negative feedback, FSH, LH will be high. So what will be your answer? Increased FSH, increased LH, decreased estradiol. Is that okay? Now we'll talk about Sheehan syndrome. Okay, Sheehan syndrome is basically what compartment problem? Compartment number 2, which is pituitary problem, and you know what? FSH, LH will be less, and estradiol also will be less. Okay, so this is direct. And PCOS is one problem where you have LH greater than FSH in the ratio of 2:1. This you have to remember. So here we have FSH normal. FSH will be normal or low. Okay, FSH normal or low. A detailed discussion on PCOS is available, and the hormonal profilable is available, and you can watch it. Okay, so FSH levels may be normal or decreased, but LH is increased. So when you make a ratio of LH FSH ratio, it is 2:1 or sometimes even 3:1. So this is how you match. So you should have a detailed understanding of the HPOU axis for you to answer all these questions. So this also means that you commonly see the laboratory values in the OPD and start discussing the diagnosis, and never miss amenorrhea for the exams. So this is question number 10. Identify those instruments used in cesarean section. So I have just placed the images of all the instruments. This is Doyne's retractor, and these are the Carmen's cannula, the BP handle, and the surgical blade you place. This is Cusco-speculum. This is a Shirodgar's clamp, or sometimes called Shirodgar's vaginal wall retractor also. Shirodgar's clamp, your ordinary alley forceps, alleys. And this is the very peculiar green Armitage forceps. Okay, so what do you use? We use a Doyne's retractor to retract the bladder, thereby we can make an incision on the uterus. BP handle, of course, we can use. Cusco-speculum, no, it is used for visualization of the cervix, especially for procedures like Pap smear and all that. Carmen's cannula also, no, we don't use a Carmen's cannula in a cesarean section. We use it for suction evacuation. Shirodgar's clamp, maybe it can be used to retract the vaginal walls for a clear visualization of the cervix, also called cervical clamp. Okay, for doing major surgeries on the cervix, like say amputation of the cervix. Alley forceps is commonly used for holding the rectus sheath and all that during a cesarean section. Of course, green Armitage is a hemostatic type of forceps. It will compress the tissues and stop the bleeding. Now this can be applied to the cut ends of the uterus to stop the bleeding temporarily. So as such, you should know the steps of a cesarean section and all the instruments used for a cesarean section. Now this question basically checks whether you have gone to the theatre and whether you have watched cesarean section procedures and whether you have assisted cases. Okay, so you all know, first to initially make an incision, we will need this BP handle and the knife. We might need small artery clamps to arrest some bleeding. We might need alley forceps to take hold of the rectus sheath to cut the rectus sheath. Fine. We will need the scalpel once again to make a uterine incision. We will need the Doyne's retractor to retract the bladder down and find the lower uterine segment before we make an incision. Okay, and then after we deliver the baby, we will need clamps to apply on the umbilical cord. Then we will need alley forceps or green Armitage forceps to hold the uterine angle and the edges. And then we will need Vicryl with a needle holder to suture the uterus. Okay, we might need a catgut if we are additionally going to do a sterilization procedure. We might need again Prolin or Vicryl to suture the rectus sheath. So very simple instruments for cesarean section, and please know the name of the retractor. It is Doyne's retractor. Okay, so we'll start with the question number 11. Again, this is a very common scenario which you see in the obstetric OPD. Now this is a 35-year-old second gravida with a previous normal delivery. Now she's in the 3rd trimester. Presents to you to the antenatal OPD with a BP of 150/110. So it's severe, right? With a proteinuria of 3+. As a routine, you want to rule out imminent eclampsia by asking for warning symptoms. All of the following are imminent symptoms except, you all know that there are 5 warning symptoms. What are the 5 warning symptoms? Headache, nausea, vomiting, blurring of vision. Okay, actually after headache, I should have told you blurring of vision. Okay, so that is how you remember blurring of vision. Epigastric pain. Patient complains of epigastric pain, oliguria. You ask her for the urine output, and if she says less, these 5 symptoms, if she has even one symptom, that means it is imminent eclampsia. Okay, she might throw a fit any time in future. So which of the following is the option that is left out here? Persistent bilateral pedal edema has nothing to tell you about the whether she will go in for eclampsia or not. Okay, now when we talk about the basics of preeclampsia, we have so many new things that have come. Therefore, you should be very clear about all the new concepts that have come into the diagnosis of preeclampsia. You all know we make a diagnosis of preeclampsia only after 20 weeks. Question number 1 is, what is high BP in pregnancy? When do you say BP is high in pregnancy? What is high BP in pregnancy? A BP value of more than or equal to 140/90, either systolic or diastolic, more than equal to. Okay, so if it's 140/80, it's high BP. Okay, it's 110/90, then it is also high BP. So please understand, more than or equal to. So after 20 weeks, if you have a combination of increased BP, which is more than or equal to 140/90, in the first occasion of diagnosis, you should at least find this elevated BP on 2 occasions, 4 hours apart. It's not 6 hours apart, it's 4 hours apart. Then you make a diagnosis of high BP in pregnancy. So you make a diagnosis of high BP plus proteinuria after 20 weeks, then you call it preeclampsia. Then you call it what? Preeclampsia. So after 20 weeks, a combination of elevated blood pressure and proteinuria is preeclampsia. Now please understand, how do you define proteinuria? If you are doing it with a dipstick, then it should be 1 plus or more. It's not trace. If trace, then it is insignificant. It's not significant. So this is significant proteinuria. It's not just a trace. So what level of proteinuria is significant enough to diagnose preeclampsia, you should understand. Okay. Now, if it's a spot measurement, if it's a spot protein, you're sending the urine sample, and if it's a spot protein analysis of the urine sample, it should be more than or equal to 0.3 grams per liter, or this we call as 30 milligram per deciliter. All are one and the same. Now, if you are giving a 24-hour collection, which is cumbersome and which is not done nowadays, it's just a textbook description, it's more than or equal to 300 milligrams in a 24-hour collection. And our latest, what we are doing, which you all should know, is urine protein creatinine ratio. Urine protein divided by urine creatinine, which we call as urine protein creatinine ratio, which shortly I am going to write urine PCR. Now, if this urine PCR is greater than or equal to 0.3, then you make a diagnosis of preeclampsia. Now, it's simple. A patient comes after 20 weeks, BP is 140/90, urine PCR is 0.3. We easily make a diagnosis of preeclampsia. So, I hope you understand this. Please make a note of this urine PCR. Now, this is a very important point. So, how things have evolved? In the diagnosis of preeclampsia? Earlier, we used to have a triad of elevated BP and proteinuria and pedal edema. Now, this pedal edema is totally gone from the diagnosis of preeclampsia. We don't bring it inside for the diagnosis, because pedal edema you see in cardiac failure, you see in liver failure, you see in anemia, you see in hypoproteinemia. No. So, we are not, even physiological also. So, we don't bring in. So, BP and proteinuria. Now, please understand another important point which has evolved recently. Even in the absence of proteinuria, if proteinuria is not present, in the absence of proteinuria, if you have any of the 5, if you have any one of the following 5 important conditions which I am going to tell you, then also you can make a diagnosis of preeclampsia. Number 1, if her serum creatinine is going to increase. If a serum creatinine increases twice the pre-pregnant value or twice the booking visit. Okay, this is number 1. Number 2, if her liver enzymes ALT and AST is going to again increase twice the level, then again you're going to call it as preeclampsia. Is that okay? If she presents with pulmonary edema, if she presents with pulmonary edema, even without having proteinuria, you can diagnose preeclampsia. And if she presents with serum platelets, less than 1 lakh, you can diagnose preeclampsia. Okay, or if she presents with any of the imminent symptoms which we have discussed. Okay, now why am I talking about all this? You have a patient coming to the OPD who comes with elevated BP of say 140/90 or 150/100. Now you ask her to go to the lab to check her proteins. Say, do you do a urine PCR or a spot protein or a dipstick, whatever. If it's coming, there is no proteinuria, you cannot simply say, no, she's not a case of preeclampsia. You have to check for all the other 5. Please understand, you have to check her serum creatinine, you have to check her AST, ALT, you have to check her serum platelets, and of course, pulmonary edema that clinically you can assess, and you have to ask her for imminent symptoms. Now, rarely you have a combination. You have a woman with 140/90, she says headache, then immediately you make a diagnosis of preeclampsia. So, all these things are important. So, increased BP plus proteinuria is equal to preeclampsia. In the absence of proteinuria, if you have any of the 5, very easy to remember, liver, kidneys, lungs, platelets, imminent symptoms, then you can make a diagnosis of preeclampsia. Now, is that correct? Previously, in this list, a UGR was there. Now it is not there. So please also make a note of this point. So any end organ damage, increased BP and signs of end organ damage, even without proteinuria, you make a diagnosis of preeclampsia. So all these things are very common to the OPD diagnosis of preeclampsia. So you might have questions on these points. Okay. So we'll start with the next question. This is a 35-year-old female, para 2, living 2 children with previous 2 normal deliveries, presents with pain abdomen. The pain is dull aching and not radiating. Her LMP was 20 days back. A clear left ovarian cyst of 5 centimeters is detected on ultrasound. Now, basically, this is a question on management of ovarian cyst. Fine. So, whenever you see a question on management of ovarian cyst, please focus on the age, because you need to classify whether this is pre-menopausal ovarian cyst or post-menopausal ovarian cyst. We have different guidelines and the management is entirely different. Okay, so now we are going to talk about management of pre-menopausal ovarian cyst, and let's look at the character of the cyst. This is a clear cyst, 5 centimeters. So, this is a simple cyst. When do you say the cyst is complex? When the cyst wall is thick. Okay, I'll write certain features. So this is a thicker cyst wall. When the cyst wall is thick. When the cyst has septations, that is, the cyst is multilocular. Cyst is multilocular and the cyst has septations. And when the cyst has some solid areas. This is when you call it as a complex cyst. But here the question clearly says what? A clear left ovarian cyst. So this is a single cyst, only one side, left side, and it is simple. It has no, we assume it is not multilocular, no septations and no solid areas. Now what is the best recommended management? Now we will talk about the management of ovarian cyst. Okay, so when we are talking about management of ovarian cyst, I go by the latest guidelines, which is Green Top Guideline number 62. So which says the protocol for management of ovarian cyst. Okay, so basically before you classify any ovarian cyst, you need to find the risk of malignancy index for the cyst. So I'll write here the risk of malignancy index. How do you calculate the risk of malignancy index for any cyst? Risk of malignancy index. We have a formula which is U into M into CA125. Fine. Here U stands for ultrasound characters. U stands for ultrasound characters. This M stands for whether she is pre-menopausal or post-menopausal. Now you give a score of 1 if she is pre-menopausal. So this patient is pre-menopausal, she is only 35 years, you give a score of 1. You give a score of 3 if she is post-menopausal. So from this simple point, what do you understand? The same cyst, you have a cyst with the same characters. The same characters, if you see that cyst in a post-menopausal lady, now the chance of malignancy or the risk of malignancy index increases 3 times. It is 3 times more probable that it could be malignant. You understand? So this number will become 3. Okay, now when we talk about ultrasound, we have 5 important characters. I usually remember it with a mnemonic. I always remember SBA M square, single best answer question, most important. So most, M. So that M 2 times. Okay. So S for solid areas, B for bilaterality, A for ascites, M for metastasis, and next M for multilocular. Okay, so we have a cyst and we are going to calculate the risk of malignancy index for the cyst. And please remember, if you don't have any of these characters, then the score will become 0. If you have one feature, the score will become 1. Now we are talking about U. Okay, now if you have greater than one feature, now the score becomes 2. And what was given in the question? We had seen a 5 centimeter clear cyst. So is there solid area? We'll strike out no solid area. Is it bilateral? No. Ascites not given. Metastasis? No. Is it multilocular? No. So what will happen to the U in the risk of malignancy index? It becomes 0. Therefore, now for this cyst, risk of malignancy index becomes 0. We have not even taken CA 125 into consideration. So please understand that point. Now, this is a clear cyst of 5 centimeter with risk of malignancy index is equal to 0. How you are going to manage? Okay, so now if we have confirmed that it is a simple cyst, and we have also confirmed the age, and now she is premenopausal. As per the Green Top guidelines, now we always stick on to these guidelines because it is latest. If we have the cyst less than 5 centimeters. So before that, all of you please understand, when do you call ovarian cyst? We call ovarian cyst when the size is more than 3 centimeters. We call it as a cyst when it is equal to or more than 3 centimeters, because even the dominant follicle is 2 centimeters. Before rupture, the dominant follicle itself is 2 centimeters. Yes or no? Okay. So if the cyst is less than 5 centimeters, the Green Top guidelines strictly says no follow-up is needed. You need not give oral contraceptive pills. You need not do a repeat ultrasound. These cysts are almost always physiological. Is that understandable? So less than 5 centimeters, it says no follow-up. When the cyst is somewhere between 5 to 7 centimeters, we say ultrasound, but the Green Top guideline says yearly ultrasound. Maybe in the Indian scenario, when people are not willing to wait for a year, you might consider doing them once in 3 months or once in 6 months. So this is for the Indian scenario maybe. Okay, but actually what the guideline says, you can do yearly ultrasound. Because you know that cyst is simple. It is not showing any of these complex features, right? Okay. Now, if the cyst is more than 7 centimeters, a biopsy is needed. Therefore, please do a laparoscopic removal of the cyst. It's always advisable to do a laparoscopic removal of the cyst. You're not going to do a CT or a MRI and all that. Better we get the cyst and subject it to histopathological examination. So that is it. Now, this is the latest Green Top guidelines and cyst of less than 5 centimeters. So here the question, you have the cyst is equal to 5 centimeters. So you can take this. The cyst is equal to 5 centimeters. So it is yearly ultrasound. What option do you find? CA 125. What is the best recommended management? No, we are not going to do CA 125 for her. It is a simple cyst. And with the cyst character itself, risk of malignancy index becomes 0. So we need not even check CA 125. Diagnostic laparoscopy, we are not going to do. We are not going to do a CT abdomen. Follow up. Actual guideline says yearly ultrasound. But maybe for the Indian scenario, you can, because our patients are much more anxious, you can try doing a scan, follow-up by 2 to 3 months later on. Is that okay? So I hope you understand. Please understand that the guidelines for management of post-menopausal ovarian cyst is entirely different. There, as a first step, you will do a CT and a CA 125. So when you have a question on ovarian cyst, please look at the age first. Please look at the cyst characters. Also try calculating risk of malignancy index. Confirm that it is only a simple cyst. So after you have confirmed it's a simple cyst, start applying the guidelines. Is that okay? I hope things are clear here. And also please remember the formula for calculating the risk of malignancy index. Fine. Now this is a very important question. Which of the following is not a component of active management of third stage of labor? Not a component. So we will first go and discuss active management of third stage of labor. So we all know what is third stage. Third stage is a stage between the delivery of the baby and the delivery of the placenta. So now we will start with writing the important points. So baby delivered. Okay. Now I'll draw a rough picture. Pardon me for the picture because I just want you to understand now what's happening. Now baby delivered. So the first step in active management of third stage is uterotonics. So let's write it. Uterotonics immediately after delivery of the baby. Each and every word here is important. Uterotonics immediately after delivery of baby. Uterotonics immediately after delivery of baby. So here please focus on this word immediately. What do you mean by this word immediately? This immediately means within 1 minute. Within 1 minute. That is within 60 seconds. You're not going to take so much time. Within 60 seconds, you're going to give uterotonics. Within 60 seconds, you are going to give uterotonics. Within 60 seconds of baby delivery, you want the uterus to contract. So what uterotonics are you going to give? We have lots of uterotonics. We have oxytocin, we have methergin, we have oxytocin, we have methergin, we have our prostaglandin F2 alpha, which is carboprost. We have prostaglandin E1, which is misoprostol, which is available as a tablet. Okay, so the preferred uterotonic is always oxytocin. Is always oxytocin because oxytocin has the least side effects. Oxytocin has the least side effects. You know, methergin is contraindicated. Methergin has two important contraindications. Mainly, it is contraindicated in a woman with heart disease. I hope you all know this because it will precipitate a failure. It is also contraindicated in hypertension, any form of hypertension, be it preeclampsia or gestational hypertension, or she had a pre-existing hypertension, which is called chronic hypertension. Okay, so it's contraindicated. You do have relative contraindications like an Rh negative mother, wherein if you give methergin, the chance of fetal-maternal hemorrhage might increase. So methergin has lots of complications. So every time you're going to give it to your patient, you have to check whether she has these complications or not. So it's leave of methergin. Even this prostaglandin F2 alpha is contraindicated in a woman with bronchial asthma. It will precipitate a asthmatic attack. Okay, and this PGE1 is also contraindicated in a woman with a uterine scar. Okay, so of course after delivery you can give, but you still need to be careful. You need to be careful. Okay, so the best drug here is oxytocin. How much oxytocin? What does FIGO say? FIGO says we can give 10 units oxytocin. 10 units oxytocin is actually 2 ampules. You know, 1 ampule, which is 1 ml of oxytocin, is 5 units. So 10 units of oxytocin is given IM to the mother, preferably in the gluteal region. Okay, so 10 units oxytocin IM is preferred for a vaginal delivery. And RCOG and FIGO also says if it is LSES, the anesthetist might prefer to give a 5 unit oxytocin slow IV. Oxytocin should not be given rapid IV. It will cause hypotension and arrhythmia. Okay, so please remember that fact also. Rapid IV injection of oxytocin has 2 important side effects. It will cause hypotension and arrhythmia, so you should not give it. Very carefully, anesthetist will give it slow IV. Okay, so I hope I have made it clear. So within 1 minute of delivery of the baby, you are supposed to give oxytocin. Now this will help in initiating uterine contractions. I hope all of you are able to understand this. Now this uterotonic step, this alone decreases the risk of PPH. Decreases the risk of PPH by 60%. Now this alone decreases the risk of PPH by 60%. Is that okay? So first step, I hope all of you are able to clearly understand. Now number 2 step, again imagine now you have given oxytocin. You have made your assistant give oxytocin. Now you are holding the baby here. When to clamp the cord? Very, very important. Please do the cord clamping. Please have a small delay in cord clamping. This is delayed cord clamping. How long we should delay? We can delay till the cord pulsation stops. Now this gives some amount of extra blood to the baby. Till cord pulsation stops. This gives some amount of extra blood to the baby. That some amount of extra blood will prevent neonatal anemia. Usually cord pulsation stops in 1 to 3 minutes. So you can delay the cord clamping for 1 to 3 minutes. Now, so you have clamped the cord. What are you going to do next? The third step. So clamp the cord. Okay, the third step, cord clamping done. So next step, what you're going to do is you're going to deliver the placenta. The delivery of the placenta should be by controlled contraction. I hope all of you know controlled contraction. Now this controlled contraction only after signs of placental separation, so that this step exactly prevents the inversion uterus. Okay, so now this maneuver is called Brand-Andrew technique. Now this maneuver is called Brand-Andrew maneuver or Brand-Andrew technique. So that is it. So this is all the steps. Now FIGO also adds a step, like if uterotonics were not given, or if you feel that the uterus is still a bit atonic, you can prefer to do uterine massage. Uterine massage. WHO has given up this uterine massage long back, but FIGO still says uterine massage has a role. Okay, and usually after delivery, you are supposed to check uterine tone. We all know that a well-contracted uterus is the tone of a well-contracted uterus is equal to the tone of a cricket ball. It will be that hard like a cricket ball. So you're going to check uterine tone. How often are you going to check uterine tone? Every 15 minutes. Every 15 minutes for 2 hours. And if you feel the uterus is a bit atonic, definitely uterine massage can be done. So please understand these are the steps of active management of third stage of labor. Now I think we'll go back to that question and see uterotonics after delivery of the placenta. Of course, it's not after the delivery of placenta, it's after the delivery of the baby. Okay, so we'll read all the statements and then we'll find out. Early cord clamping, definitely not. Uterine massage, okay. Control contraction, yes. Both A and B statements are a bit wrong, but when we say we have to choose a single best answer, now I am going to go with this answer because we are definitely not including early cord clamping with the intention of preventing a neonatal anemia in the baby. We are definitely doing only delayed cord clamping. So here single best answer will be, we'll go with early cord clamping. Although the statement A is also not correct. It's not uterotonics after delivery of the placenta, it's after delivery of the baby. And that too within 1 minute. Okay. Okay. So let's go to the next question. And this is a very simple question. Which of the following is a feature of the karyotype shown in the picture? So when we carefully look at the karyotype, we find what? XXY. This is XXY. Now this is a karyotype of Klinefelter syndrome. Klinefelter syndrome. Klinefelter syndrome is a cause of azoospermia and it is a testicular cause of azoospermia. So when we classify azoospermia, we classify the hypothalamic. Now this is hypothalamus, this is anterior and posterior pituitary, and we classify, now this is the testicular causes and then the post-testicular causes. So whenever we classify azoospermia, we classify it as pre-testicular causes, and then we classify it as testicular causes and post-testicular causes. Yes. Now, this is pre-testicular cause of azoospermia, where there are problems with the hypothalamus or the problems with the anterior pituitary. Say a problem with the hypothalamus, we will talk of Kallmann syndrome. Pituitary causes, we can talk of trauma to the pituitary, meningitis, encephalitis, pituitary tumors, so many other syndromes, anterior pituitary syndromes. Now in all the pre-testicular causes, the FSH and LH will be low and therefore the serum testosterone levels also will be low. Now this is the hormonal profile in a pre-testicular cause. Now when we talk about a testicular cause, there are lots of testicular causes like exposure to radiotherapy or exposure to chemotherapy, when there is torsion of testis, when there is a very big varicocele, or when there is a very big hydrocele, our Klinefelter syndrome. Okay, this Klinefelter syndrome, the testis is atrophic, size of the testis is small, atrophic testis. So Klinefelter syndrome, these are all testicular causes. So in testicular causes, basically there is impaired spermatogenesis inside the testis. Okay, so here what happens is the FSH, testosterone production by the testis is very low, so serum testosterone is low, but because there is no negative feedback, now FSH and LH is increased. Is that understandable? So testicular cause, you will find this sort of a hormonal pattern. Now when we talk of post-testicular cause, it can be anything. Vasectomy is a post-testicular cause. Congenital bilateral absence of vas deferens is a testicular cause. Epididymitis, seminal vesiculitis, all these are post-testicular causes which can cause obstruction. Okay, so in all the post-testicular causes, FSH, LH will be normal and serum testosterone also will be normal. So you might get questions based on these hormonal patterns. So please, because in previous AIMS exams we had questions on this. So this is the hormonal profile in a pre-testicular cause. Now this is the hormonal profile in a testicular cause, and this is a hormonal profile in a post-testicular cause. So please make a note of it. Here Klinefelter will come under what? 47XX. Why Klinefelter comes under testicular cause? So definitely serum testosterone is low and FSH and LH will be high. And we know all the phenotypic features like lack of body hair, they are tall, gynecomastia, and testicular atrophy, infertility, and azoospermia. So here when they had just asked us the phenotypic features, short stature and mental retardation, no. Short stature, no. Tall stature and gynecomastia, yes. Okay, so they had just asked the phenotypic features, so it is very, very simple. I think the next question is on polycystic ovarian syndrome. No question paper is complete without a question on polycystic ovarian syndrome, because it's assuming epidemic proportions. We have so many cases of PCOS. That is all related to the lifestyle changes. Now let's look at this scenario. Now this is a 26-year-old female who presents with hirsutism, oligomenorrhea, and she is anxious to conceive. She is diagnosed with PCOS. Now we have a case scenario which is PCOS plus infertility. And which of the following is not helpful in the management of this patient is our question. So which is not helpful, they are asking. Okay, so first let's look into basics of management of polycystic ovarian syndrome, and then we will discuss it. Okay, polycystic ovarian syndrome, also called by this name Steen-Leventhal syndrome. It's very important how we diagnose polycystic ovarian syndrome. So we have this traditional diagnosis which is Rotterdam criteria. This is a consensus criteria which was accepted until this is in date. This is followed now. This consensus opinion was formed, say, in the year 2003. So here we need to look into three important features. Okay, so we need to look into three important features. The first feature is oligomenorrhea, which is irregular menstruation. Oligomenorrhea is infrequent cycles. You all know it is infrequent cycles. So what does this say? Oligomenorrhea means anovulation. It means anovulation. Number two, features of hyperandrogenism, like the woman complains of hirsutism, or she complains of acne, or she has biochemically elevated androgens. And this is ultrasound appearance, at least one ovary showing the 12 follicles, okay, which are peripherally arranged with the necklace pattern. Now this is ultrasound appearance. Please understand that it is if you have any 2 out of 3 from these features, then you can make a diagnosis of polycystic ovarian syndrome. Is that understandable? So here you had AIMS exam questions in previous years, like they will give only anovulation and hyperandrogenism. this and this, and in the question will say that ultrasound is normal, both ovaries are normal. Please understand, even then you can make a diagnosis of PCOS as per the Rotterdam criteria. Yes or no? So please don't be carried away by the ultrasound appearance being normal. It is PCOS. Now this patient can come with any of her complaints may be irregular cycles, delayed cycles. Her complaint may be hirsutism. Fine. Her complaint may be infertility. So we have 3 patient profiles usually coming in PCOS. Patient profile number 1. Patient profile number 1 is usually, say for example, you have a 18-year-old or say a 20-year-old unmarried girl, sometimes even adolescent girls we have, who are brought by her mother. Mainly the complaint is irregular cycles or delayed cycles, or the main complaint is oligomenorrhea. So what is needed for her is cycle regularization, or we can say cycle correction. So how do we regularize her cycle? Cycle regularization can be done with combined oral contraceptive pills, and as I told you, the best combined oral combination for combined oral contraceptive pill, I will discuss some few minutes later. But when you give combined oral contraceptive pill, her cycles get regularized. Profile number 2. So if this is her complaint, you can obviously the diet, lifestyle management, cutting off easily digestible sugars, all that is important. You can even add metformin, all that. This is with regard to her symptom per se. Okay, so for cycle regularization you can give OC pills. So profile number 2 may be married 25, 26 years or 30 years or 35 years. Okay, she is married and she is anxious to conceive. Her main complaint is infertility. I mean, now if this is her complaint, now of course your weight reduction, of course the metformin, everything will come, but you are mainly going to give her ovulation induction. Ovulation induction. So when we talk about ovulation induction, the most commonly used ovulation induction drugs are clomiphene citrate, gonodotrophin, so you have FSH. Letrozole is a very important ovulation induction drug, which is an aromatase inhibitor. You have gonodotrophins, you have clomiphene citrate. You can also use combination like CC plus FSH, CC plus letrozole and all that. And we also have GnRH analogs regimen with GnRH analogs. Okay, we have this protocols, a long protocol, short protocol. We'll not go into details. Here, please remember that tamoxifen is also anti-estrogen, can also be used for ovulation induction, though commonly it is not used. Okay, now we'll come to profile number 3. Profile number 3, she is not worried about her cycle correction or cycle regularity, or she is not anxious to conceive. Her main worry is the hyperandrogenism. The hirsutism and acne is her main worry. So in that case, again with all the general measures for PCOS, we have to treat her with anti-androgens. We have to treat her with anti-androgens, and the 4 anti-androgens that are commonly available are spironolactone, cyproterone acetate, we have finasteride. Finasteride is a 5-alpha reductase inhibitor, and flutamide. What is flutamide? Is an androgen receptor blocker. Okay, so we have all these drugs, and you can also use the combination, combined oral contraceptive combination, where we have ethinyl estradiol, and instead of progesterone we have drospirenone, which is a spironolactone analog. Okay, now this is the best OC pill to treat polycystic ovarian syndrome. Now drospirenone, since it's a spironolactone analog, it also has the anti-androgenic features. Now when we look at this question, which is not useful, so infertility, so clomiphene citrate is ovulation induction drug, yes, can be given. Tamoxifen also can be given, metformin also can be given. But when we talk about combined oral contraceptive pills, how is it helpful in infertility? No. So therefore the odd man out will be combined oral contraceptive pills. Many of you are tempted to answer tamoxifen, although tamoxifen is not regularly used as a ovulation induction drug, it does have some role. Okay, so here combined oral contraceptive pill, we will take this off. Okay, so question number 16, identify the fetal anomaly. So here, though you can see the fetus here, maybe it's something around say 11 weeks, 12 weeks scan you're seeing, and what you're seeing is complete absence of the cranial vault. So the best diagnosis for this question will be anencephaly. Though some of you might be tempted to write encephalocele because you slightly see a frontal protrusion here. You might be tempted to write encephalocele, but that is not the answer. Okay, that's not the answer because you are not seeing the cranial bone, cranial vault as such. If you're seeing the vault, no, it should be like hyperechoic. See, like this line. It should be hyperechoic. You should be able to see the vault like this, which you are not seeing here. So this is definitely anencephaly. Okay, and a beautiful, actually the typical ultrasound description of anencephaly is this frog eye appearance or Mickey Mouse appearance, which is best illustrated with this picture. But this picture, if it was given, then all of you would have written easily, but I hope this picture was not given. The sagittal view of the baby fetus was shown. Okay, and specific points regarding anencephaly is, you all know that it is the absence of cranial vault. Though the development of forebrain is abnormal, but the development of midbrain and hindbrain might be normal. Okay, now basically this is a neural tube defect, and you all know that neural tube defect is because of deficiency of folic acid. You all know that it is because of deficiency of folic acid, which is vitamin B9. Okay, and we should also know that definitely there is a risk of recurrence. A risk of recurrence is there with the neural tube defects. If the mother gives a history of having one baby with neural tube defect, the risk is 5%. 2 previous babies with neural tube defect, the risk is 13%. And 3 babies with neural tube defect, the risk is as high as 25%. So this is traditional percentage values which we all know. Okay. 2 important associations of anencephaly is that the first point is that anencephaly is 4 times more common in female babies compared to male babies. Okay, female babies when compared to male babies. Anencephaly is strongly associated with polyhydramnios. Is strongly associated with polyhydramnios. That is because there is exudation from the meninges. Not only that, the swallowing by the baby is also defective, so it's usually associated with polyhydramnios. And anencephaly, obviously this is a indication for MTP. It's a fetal indication for MTP, but we very rarely see term anencephaly nowadays. But if that is the case, if you have a term anencephaly, then labor usually sets in very late. That pregnancy will go for postdatism. That is because anencephaly, since the fetal pituitary is not there, since pituitary hypoplasia, so pituitary hypoplasia. So please understand this concept. For the initiation of labor, we always have the fetal cortisol playing a very important role. But here, because the fetal pituitary is hypoplastic, the adrenocorticotropic hormone from the pituitary is also not there. So fetal adrenal cortex, the adrenal cortex is hypoplastic. So fetal cortisol is not there. So labor is not getting initiated properly. So all this is very important. Now, when will you be able to diagnose this anencephaly by ultrasound? This is a very common question that is asked. Usually as early as, it is seen as early as 11 weeks with certainty. Okay, as early as 11 weeks with 100% accuracy. You will be able to diagnose it with 100% accuracy by 14 weeks. So by the time the woman comes for her NT scan, you should be able to diagnose anencephaly. It's not the one which is usually diagnosed only in your anomaly scan. You can always with 100% certainty diagnose it even during the nuchal translucency scan. Is that okay? So now these are the very important points regarding anencephaly. And regarding the other anomalies that are given as other options, see, encephalocele is meningoencephalocele, also known as, is a form of a neural tube defect where the brain tissue on the overlaying meninges herniate through the defect in the cranium. So here classically you see that you are able to visualize the cranial bone. Cranium you are able to visualize. There is a defect through which you see the herniation. Okay, but anencephaly, the whole of the cranial vault is not there. So that is the difference. Okay. And this is the omphalocele. You can see that there is herniation of the abdominal contents through the umbilical cord. This is omphalocele. This is omphalocele. And here you can see the fetal head, and here a swelling in the region of the neck, which is cystic hygroma. Is that okay? Now this is cystic hygroma. Okay, so the other options in that question, now I think all of you are absolutely convinced regarding the answer for this question. It should be anencephaly. Okay, it's not encephalocele, though you see a protrusion here. Entire head you are not seeing the cranium. Okay, so encephalocele you cannot take amphalocele, and you cannot take it as cystic hygroma. Okay. Okay. Which of the following is not a branch of anterior division of internal iliac? Though we say it's an anatomy question, this question gains importance in obstetrics because internal iliac artery is very important. Internal iliac artery ligation we do where? We do it in cases of PPH. So branches of anterior division of internal iliac, posterior division. Usually you do get questions like all of the following are branches of the anterior division except. So I always prefer to remember branches of posterior division with a small mnemonic SIL. Okay. S for superior gluteal. Superior gluteal. I iliolumbar. Iliolumbar, lateral sacral. So many times I have seen this question in the exam. Okay, many of you might be wondering like why I should remember all these branches. Okay, very important from the obstetric point of view. And regarding anterior division, first I remember is bladder. Bladder is always anterior. Remember superior vesical artery, inferior vesical artery. I don't have any mnemonic to remember this, but I usually remember bladder is anterior structure usually, so superior vesicle, inferior vesicle. We don't have middle vesicle. So instead of middle vesicle, we write middle and the posterior most structure, which is middle rectal. Okay. Our very important artery, which is the uterine artery, arises from this branch. Sometimes a separate vaginal branch also arises here. Okay. Another very important artery that comes here is internal pudendal artery. So internal pudendal artery is a branch. Okay, and I also remember that obturator is a branch. Okay, and finally before we write superior gluteal, here remember inferior gluteal is also a branch of the anterior division. So that is how I remember, may be helpful for you. Superior vesicle, inferior vesicle, it's middle rectal. Then the most important uterine artery, vaginal artery, most important internal pudendal artery, of course the obturator. I also include inferior gluteal. Okay, for this I remember a mnemonic. And let's therefore answer here, which is not a branch of the anterior division. It's very simple. Superior gluteal is a branch of the posterior division. Fine. Now here, this is the common iliac artery bifurcating into the external iliac artery. This external iliac artery continues as the femoral artery. This. Now this is the internal iliac, which again has an anterior branch and a posterior branch. So when we do internal iliac artery ligation, please do not ligate here. You are supposed, this is wrong, you are supposed to take at least 5 centimeters away from the bifurcation of the common iliac. See, this is the place where you have to ligate the internal iliac artery, because you are not supposed to include the posterior branch. If you include the posterior branch, then the patient will have severe claudicating pain in the lower limbs, of course in the gluteal region also, because the branches of the posterior division are included. Okay, and also note that internal iliac vein, okay, is exactly posterior to the internal iliac artery. The tributaries of internal iliac vein is posterior, and you must take utmost care not to damage the internal iliac vein. Okay, so that's another important point in this ligation. Is that okay? Question number 18. Which of the following investigations are helpful in diagnosing unicornuate uterus? Okay, so this is a very easy question and a very simple question. So this is a question with reference to Mullerian anomalies. We all know that the Mullerian duct, we have 2 Mullerian ducts. Okay, so this is, we'll draw like this. We have 2 Mullerian ducts. So say this is one Mullerian duct and this is another Mullerian duct. These 2 Mullerian ducts will fuse with each other. Okay, will fuse with each other. First they develop and then they fuse with each other. See, one Mullerian duct develops and then the fusion occurs. They fuse with each other to form the uterus. Okay, the fusion usually occurs from below upwards like this. Okay, and Therefore, please understand that the unfused portion of the Mullerian duct, the unfused portion of the Mullerian duct develops into the tubes. The fused portion of the Mullerian duct develops into uterus, cervix, and upper 2/3 of vagina. So this is basically Mullerian duct development. Of course, after all this develops, what happens? There will be a central septum. This central septum will disappear. Okay. This central septum will disappear and you will get a structure like this. Okay, so that is basically the development. Okay, generally to diagnose all the Mullerian ducts, please remember in olden days this is the evolution of diagnosis. In olden days, hysterosalpingogram was used. What is hysterosalpingogram? We will inject a dye into the uterus via cervix, a radio opaque dye, and we will take an X-ray and we will find. Okay, it will fill the cavity and come out of the tubes. Of course, HSG is also a tubal patency test. And please remember, HSG will be able to tell only the cavity problem, not the problem in the uterine wall. Okay, so HSG was a test. With the evolution of ultrasound and with the evolution of 3D ultrasound, we are able to get a very good picture, and now we also have the MRI with us. Okay, now we also have laparoscopy, where we can see the external surface of uterus. When combined with hysteroscopy, we can also see the internal view of the uterus, like whether there is a septum and all that. So 4 pillars or 4 important investigation any uterine anomaly is HSG, 3D ultrasound, MRI and laparoscopy. If someone asks what is the best for all the Mullerian anomalies, I would say, see, MRI is the best. MRI, but now we have our 3D ultrasound, which is still cheaper. Okay, so 3D ultrasound and MRI will come as the best investigations. But when we ask the first line investigation, still HSG has a role. Though we say it's an X-ray, still HSG has a role. Okay, laparoscopy, hysteroscopy also have a role, especially when we have lesions like septate uterus, where you can do the resection of the septum via hysteroscope. Okay, so here this question is not aimed at asking what is the best. This question aims at asking what are all useful. Will you be able to diagnose a unicornuate uterus with hysterosalpingogram? Yes. Will you be able to diagnose unicornuate uterus with laparoscopy? Yes. Will you be able to diagnose it with falloposcopy? No. The falloposcopy is putting a cannula through the uterine cornu and through into the tubes and visualizing the tube. This is simple X-ray. Please say simple X-ray will not show you the uterus. You have to put some dye inside and make it a hysterosalpingogram for visibility. So B and C. So let us choose B and C. Now what is unicornuate uterus? Basically, it is development of only one Mullerian duct. So you have only one Mullerian duct developed like this. The other Mullerian duct has not developed at all. The other Mullerian duct may be present as a rudimentary horn. It may have a cavity, may not have a cavity. The cavity may be communicating with the main cavity or may not be communicating. Fine. So unicornuate with or without rudimentary horn, with or without cavity, with or without communication. So you have lots of varieties of unicornuate uterus. Now let's look at the pictures. Now this is the HSG of a unicornuate uterus, where you can see a banana shaped uterine cavity and deflected to one side. Okay, banana shaped uterine cavity, and you can see it is deflected to one side. So this is very typical of the hysterosalpingogram. Provided there is a rudimentary horn with a cavity which is communicating, then the dye will go into the cavity and maybe it can show. But if it's a non-communicating rudimentary horn, it will not show. This is a very beautiful MRI image of a unicornuate uterus. You see the same picture here. Okay. Now this is the 3D ultrasound. 3D ultrasound. I have placed 3D ultrasound images of almost all the uterine anomalies. See here, you see the normal uterine cavity. Now this is unicornuate uterus. Okay. Now this is uterus didelphys. Now this is bicornuate uterus. So you see almost all the uterine anomalies here. So this is 3D ultrasound. We also placed a laparoscopic picture of, see, now this is the unicornuate uterus, where you can see the non-communicating uterine horn. Now this is a rudimentary horn. So you can diagnose uterine anomalies with hysterosalpingogram, with laparoscopy and hysteroscopy combined, with MRI, also with 3D ultrasound. So here I think I have marked the answer for this question. The following are causes of primary amenorrhea in a female and match the conditions with their corresponding karyotypes. Okay, so that is the question here. Wait a minute, I hope we have 2 questions on this, and I hope I will do some justice by talking to you about primary amenorrhea, the causes and all that. Okay, so before we go on to, we'll finish off the marking first. We all know Turner is 45XO, MRKH is 46XX, Swayers is 46XY, with Swayers is pure gonadal dysgenesis. Androgen insensitivity syndrome is 46XY. Okay, so before, please make a note of this and let me talk to you about primary amenorrhea. I have designed a small table to easily understand primary amenorrhea, the 3 main causes. We all know that. You can take this table. The 3 main causes of primary amenorrhea are: the first most important cause is Turner syndrome. The second most important cause of primary amenorrhea is Meyer-Rokitansky-Kuster-Hauser syndrome, which is also called Mullerian agenesis. And third most common cause of primary amenorrhea is testicular feminization syndrome. Testicular feminization syndrome. It's also called what? TFS. Also called androgen insensitivity syndrome. I'll just write androgen insensitivity syndrome. Let's talk about the karyotype. We know Turner syndrome is 45X, MRKH is 46XX, and testicular feminization is 46XY. Fine. Now first we'll talk about the development. Whenever we talk about the development, we need to talk about the development of gonad. We need to talk about the development of gonad. We need to talk about the development of internal genitalia. I'll write only this and external genitalia. Okay. What about gonad? The gonad is the ovary. Why the gonad is ovary? Because of absence of Y chromosome. So when ovary will develop? Absence of Y chromosome, then ovary will develop. So gonad is ovary. What about internal genitalia? Mullerian duct develops normally. Unfused portion of Mullerian duct develops into tubes. The fused portion of Mullerian duct develops into uterus, cervix and upper vagina. We all know that lower 2/3 of vagina and female external genitalia develops from the urogenital sinus. So this is urogenital sinus. This is Mullerian duct. And gonad develops, you all know, from the gonadal ridge or the genital ridge. Because there is absence of another X chromosomes, now this ovary shrinks. All the follicles undergo apoptosis and this ovary shrinks even by 2 years of age. Okay, so the girl lacks all the oocytes. These oocytes all will undergo rapid apoptosis and then she becomes devoid of all the oocytes. Is that okay? Now let's talk about the pubertal development here itself. We are talking of amenorrhea, so we need to talk about pubertal development. I hope all of you know the steps of pubertal development. The first step is thelarchy or breast development, which I will write as T, which is dependent on estrogen. The second step is adrenarchy, which is our axillary hair, pubic hair development, which I will write as A, which is dependent on androgen. Then there is a growth spurt. I'll write like this. Then there is a growth spurt. And then there is the first menstrual bleed or menarche. Now we are talking about this because she is not attaining menarche. So I'll write a into mark here. Is that okay? Now what happens to thelarchy? Thelarchy is absent because see, this ovary will not produce estrogen. What about adrenarchy, the axillary and pubic hair development? Again, ovary is not going to produce androgen, but there is some androgen coming from the adrenal cortex. So I'll write sparse. Growth spurt is not there. She's shorter. She's a short girl. Okay, the growth spurt is not there, and then she is therefore short, and therefore see, this girl does not attain menarche. You know why she does not attain menarche? Because uterus is not stimulated by the estrogen and progesterone because the ovary is not functioning here. Okay, so in the question, if you see thelar K is not there, adrenar K sparse, axillary hair, pubic hair sparse, and growth spurt is not there, of course you will see other phenotypic features of Turner's like cubitus valgus, horseshoe kidney, I mean like coarctation of aorta. They might give you in the question the other features as well and ask for diagnosis when you write Turner. So how are we going to treat her? We need to identify this at the earliest. Give her growth hormone supplements to increase the height, give her hormone replacement therapy, that is estrogen replacement therapy, which will also help in breast development, and she can be put on cyclical estrogen and progesterone for her menstrual cycle to resume. Yes, so whenever she takes estrogen progesterone, she'll menstruate. If she's not taking estrogen and progesterone, she'll not menstruate. That is the phenomenon. Now, regarding fertility, she has to go only for donor oocytes because she does not have oocytes. So donor oocytes and IVF. Very simple. Okay. Come on, let's talk about Mullerian agenesis. This is failure of the Mullerian duct to fuse with each other and develop. So it's a problem with the Mullerian duct. So when we talk about gonadal development, ovaries are normal. Ovaries are normal. Okay. When we talk about Mullerian duct, the uterus is absent, cervix is absent, upper vagina is absent. Okay, so maybe I'll rub this off so you won't get confused. So all this is absent. Urogenital sinus develops normally, so she'll have a blind vaginal pouch with normal female external genitalia. So this is blind vaginal pouch. So let's talk about the pubertal sequence for this girl. When we talk about the pubertal sequence for this girl, breast development, axillary pubic hair development, growth spurt and menarche. Breast development is normal because ovaries are normal. Axillary hair, pubic hair is normal because ovaries are normal. Growth spurt is also normal, but the girl does not attain menarche because she does not have the uterus. I hope you understand. So in the exam, if you're asked a question like primary amenorrhea with normal secondary sexual characters, or primary amenorrhea with normal ovaries, then very simple, you can always answer it as Mullerian agenesis. So what all problems she faces and how do you manage? Vaginoplasty has to be done for coital function, and of course from the fertility aspects she has to go for surrogacy. Uterine transplantation of course is a newer development, and that also we will include here because it is, though not very commonly done, it is still a procedure being tried. Okay, so only these are the management options. Now coming to testicular feminization syndrome. Now please understand the fact that the gonad, when we talk about the gonad is testis. The gonad is testis. Why? Because Y chromosome is present. Okay, when we talk about testis is going to produce Mullerian inhibiting substance, so the Mullerian duct will not develop. The Wolffian duct develops into epididymis, vas deferens, seminal vesicles and all that. Okay, fine. Now, this is a condition where there is complete absence of androgen receptors. Complete absence of androgen receptors in the urogenital sinus. I mean, in the whole body and in the urogenital sinus, there are no androgen receptors. So the urogenital sinus is not being acted upon by androgen. So if it's not acted upon by androgen, the urogenital sinus will get converted into a blind vaginal pouch with female external genitalia. So this is a perfect example of a female phenotype with a perfect male karyotype. Okay, now when we talk about the pubertal sequence, when we talk about thelarche, axillary hair and pubic hair, the growth spurt and menarche, of course she's not going to menstruate because she's not having the uterus. When we talk about thelarche, please understand that the testis will start producing testosterone at this point of time, which will get aromatized into estrogen, and that will cause normal thelarche. Now this is a very special and a very important point. I hope all of you understand. Axillary hair, pubic hair, of course, will be absent because there is complete absence of androgen receptors in the body. Growth spurt, okay, normal. Now, if you see this combination of a perfectly normal female phenotype with a perfectly normal male genotype, I mean 46XY, but perfectly normal female phenotype, female external genitalia, normal breast development, no axillary hair, pubic hair, then please associate your diagnosis to testicular feminization syndrome. So this is the basic meaning of the word testicular feminization syndrome. Testis produces a feminizing factor which is responsible for the breast development. Okay. How do you treat? And phenotypically female, so this girl, she will continue as a female, should not create any gender confusions for her. Vaginoplasty can be done and she can have children by adoption. Okay, because she does not have the oocytes and also she does not have the uterus. So basically the planned fertility, and she can think only about adoption. So this is how you classify the 3 most important causes of primary amenorrhea. I hope I've given a complete understanding of all this. So any question can come from this, and especially with regard to AIMS questions. Now this is a very important topic. I think this table you can take to easily revise in the last minute all the 3 syndromes. Okay, so question number 20. Again, this is a question on amenorrhea. And see, this is a 15-year-old girl with primary amenorrhea. For evaluation, her breast development is normal, external genitalia is normal, a diagnosis of 5-alpha reductase deficiency is made. So how do you classify it as? Okay, so when we talk about hermaphroditism, we need to classify them as hermaphroditism. We need to classify it as true hermaphroditism and pseudo hermaphroditism. True hermaphroditism is extremely rare. This is a condition where the genitalia is ambiguous. It is a condition where the genitalia is ambiguous, in sense you will not be able to find whether it is male genitalia or female genitalia. But when we talk about the gonads, it's a combination of ovum and testis. Ovotestis. Now it's extremely rare. What is much more common is pseudo-hermaphroditism. Pseudo-hermaphroditism is basically a disparity between gonad and genitalia. So this is how you remember, a disparity between gonad and genitalia. So normally when we have testis, it should be what? A male genitalia. So now you have testis plus female external genitalia. Female external genitalia. Or the disparity can be like this. The gonad is the ovary plus male external genitalia. I hope now you are getting a clear idea of what is what. Okay. Now, based on the gonad, now we say, see, please remember it's not based on the karyotype. Based on the gonad, we say whether it is male pseudo-hermaphroditism or female pseudo-hermaphroditism. Now here the gonad is testis, so we say it as male pseudo-hermaphroditism. Okay, male pseudo-hermaphroditism. Now here the gonad is ovary, so we say female pseudo-hermaphroditism. Okay. So when we talk about the basic the external genitalia development, we all know external genitalia is going to develop from the urogenital sinus. Supposing say this is urogenital sinus. Now this urogenital sinus is full of androgen receptors. Okay, androgen receptors. If androgen is acting on the androgen receptors, now this will get converted into male genitalia. Now if there is any problem to this means what all problems can happen? What all problems can happen? One problem is there is no androgen production. No androgen production. Or the other problem can be there is no androgen receptor. I hope you are able to understand. There is no androgen receptor in the urogenital sinus. So then this will develop into female genitalia. In female, the urogenital sinus develops into lower 1/3 of vagina and female external genitalia, the labia majora, labia minora, clitoris and all the other things. So if androgen is going to act on the androgen receptor in the urogenital sinus, then it will develop into male external genitalia. If the androgen is not going to act on the androgen receptors on the urogenital sinus, then it will get converted into lower 1/3 of vagina and female external genital. I hope you are very, very clear. You should be clear on this concept. Now, imagine now here it is testis, but say there are problems like who produces testosterone in the testis? Leydig cell. So, if we have a condition called Leydig cell aplasia, if we have a condition like testis not getting converted into dihydrotestosterone, which is the most active form, like a 5-alpha reductase deficiency, if we have a condition like absence of androgen receptors in the urogenital sinus, which we call as testicular feminization syndrome or androgen insensitivity syndrome, then in all these conditions, you will see a combination of testis plus female external genitalia, which is male pseudohermaphroditism. When will you have ovary and male genitalia? When the ovary, see, estrogen is not needed for external genitalia development. Please understand. Now, in the female also, urogenital sinus will definitely have androgen receptor. But in a female, there is no testis to produce androgen. But if she is exposed to high androgen environment, like say congenital adrenal hyperplasia, where adrenal gland is going to produce more androgen, or if the mother is going to take some androgenic drugs like danazol, then the genitalia will become masculinized. So congenital adrenal hyperplasia, intake of androgenic drugs, or if the mother has a masculinizing ovarian tumor wherein the mother's ovary produces more androgen and therefore it acts on the urogenital sinus on the baby. Okay, so these are the conditions where we have a combination of ovary and masculinized genitalia, which is female pseudohermaphroditism. So what is asked in the question is 5-alpha reductase deficiency fits in where? 5-alpha reductase deficiency fits in a combination of testis plus female external genitalia, which is male pseudohermaphroditism. I hope the understanding is clear. Please don't try to memorize all this. Please understand and learn. Such a nice question this is. Okay. Okay. Ovarian reserve declines with age. Of course, we all know this ovarian reserve declines with age. Yes. 20 weeks of intrauterine life, there were 7 million oocytes in the ovary. We know. At birth, the oocytes number is reduced to 2 million oocytes, 1 million in each ovary. We know. So, at puberty, it becomes 4 lakh. At puberty, it becomes 4 lakhs, and of which only 400 will ovulate, and of course, after menopause, it declines further. So, at any point of time, we need to find out the number of oocytes, not only the number, the quality also. The number of oocytes left in the ovary at any point of time. It's like your bank account, how much money you have in your bank, in your account. So similar to that, now this concept is ovarian reserve. Okay, so for the ovarian reserve, the most important parameters are we have certain ultrasound parameters, and then we also have certain, say, biochemical or hormonal markers. In the ultrasound, we can see ovarian volume. We know that ovary shrinks with age, so ovarian volume will decrease with age. We can see the vascularity of the ovary. Vascularity will decrease with age. I'm not going into that resistance index, pulsatility index. That's not needed for the undergraduate level at all. And we have one very important point called antral follicular count. What are antral follicles? The 2 to 9 millimeter follicles are antral follicles. Okay. So when the antral follicle count is less than 4, it means that the reserve is very less. Okay. So antral follicular count. So these are the ovarian parameters. The most important hormonal parameter is anti-Mullerian hormone and day 3 FSH, basal FSH, day 3 estradiol, which I will write as E2. Also inhibin, which is not inhibin A, it is inhibin B, and let's not confuse here because this inhibin will also come in your triple marker, no? There you have to write inhibin A, so I don't want to make you confused. We'll just write inhibin. Okay, okay. To be correct, let me write inhibin B, but there's no need to remember this because don't confuse this with your triple test. Okay, so anti-Mullerian hormone levels with age declines. Inhibin level also declines. but FSH and E2 level will increase. I have explained in detail in menopause topic why this increases. Okay, so now what is given as the option? Which of the following is a marker of ovarian reserve? Is it early luteal phase FSH? No, even if it's early follicular phase FSH, it's okay. Early luteal phase estradiol? No. Early follicular phase estradiol? Yes. Anti-Mullerian hormone? Yes. But which is best? Anti-Mullerian hormone is the best, because this anti-Mullerian hormone level can be done at any time of the cycle, and it better predicts the ovarian reserve. So if you have a single best answer to be chosen for this question, then you have to go for anti-Mullerian hormone. And when we have the cutoffs for anti-Mullerian hormone, it is usually 4 to 6 nanograms per ml. Some labs also give it in millimole per ml, so don't worry. If it's less than 2.2, it's low. If it's less than 0.3, it's very low. And there's no need to remember this, because this will not be asked. No need. Okay. So anti-Mullerian hormone levels will decrease with age. Okay. So it's a better marker of the ovarian reserve. Match the following. So this question is just basically aimed at whether you have worked in your OPD. Okay. So kit 1 is for urethral discharge, and kit 2 is for the vaginal discharge. This kit 3 is for the genital ulcer, which is not because of herpes, and kit 6, actually this should be kit 6. What was asked in the question is kit 6 is for PID. So you definitely have to at least memorize all this. See, kit 1 is for urethral discharge and kit 2 is for vaginitis. What are the most common causes of vaginitis? Is Trichomonas vaginitis and bacterial vaginosis and Candida. 3 most important conditions. For Trichomonas vaginalis and bacterial vaginosis, it is secnidazole or metronidazole, so 2 grams. So that has come here. For Candida, it is tablet fluconazole 150 milligram single dose, that has come here. Okay. Now, if it is chlamydia, then you have to add doxycycline or azithromycin. Okay. So here it is given, see, cervicitis. Then you have chlamydia and gonococci as the causes. Chlamydia and gonococci. So chlamydia, gonococci will also cause what? Urethritis. Okay. So for chlamydia, the drug of choice is azithromycin. For gonococci, it is tablet cefixime 400 milligram. So for urethritis and cervicitis, it is the same treatment. Because the causative organisms are chlamydia and gonococci. For chlamydia, we give azithromycin 1 gram single dose, and for gonococci, we give tablet cefixime 400 milligram single dose. If it is vaginitis, then you have Trichomonas vaginalis, bacterial vaginosis and candidiasis. For Trichomonas vaginalis and bacterial vaginosis, the treatment is secnidazole 2 gram single dose, and for Candida, the treatment is tablet fluconazole 150 milligram single dose. So please understand and read. Okay, so see, similar to that, if it's kit 3, it is non-herpetic genital ulcer, then they think of syphilis, and therefore they add benzathine penicillin. So you have to correctly study the kits, and you also have to identify what is the reason they are adding all these drugs. Okay. Which of the following micronutrients is needed more in lactating women compared to pregnant women? I hope the answer is vitamin A, because see, the requirements of iron, calcium and folic acid are almost the same when compared in lactating women and pregnant women. But when we make a detailed study of all this is beyond your level of thinking, because you cannot sit and memorize all these vitamins. For every vitamin, the nutrient level, the recommended RDA for pregnancy and lactation. So this is one question I don't think you can answer easily. The answer is vitamin A. A few complications of twin pregnancy are listed. Which of the following complication is more common in monochorionicity? The complications which are more common in monochorionicity are the specific, the complications specific to monochorionicity are twin-to-twin transfusion syndrome, twin reversed arterial perfusion. Single fetal demise is very, very dangerous in a monochorionic twin. Of course, discordancy, IUGR, preterm labor are seen in all twin gestation, in dichorionicity also. So you can in detail study about twin-to-twin transfusion syndrome to answer this question. Now this is a very basic question. Okay. Now this is a picture of a prolapse uterus. How do you identify it as prolapse uterus? See, you can see the cervix with the cervical loss. Now this is a 3rd degree UV prolapse. So this is a uterovaginal prolapse. So very simple OPD diagnosis. Regarding the other options, now this is inversion. This is a case of inversion uterus. So what you are seeing is the entire uterus turned inside out. Now this is the entire uterus turned inside out. So what you are seeing is actually the endometrium. Clearly see here you are not able to visualize the cervix. And look at this picture. Now this is a case of a very big cervical polyp. Cervical polyp. Now when you do a pelvic examination, when you go around, when you put your fingers here at the uppermost point, you can definitely palpate the cervical os over here and this polyp protruding out from the cervical os. Okay, so that is how you differentiate. If the cervix is seen, then it's definitely prolapse. So identify. Now this is a very huge lesion on the vulva, usually post delivery or sometimes can be traumatic, and this is a vulval hematoma. Okay, the other differential diagnosis given are Bartholin cyst, vulval carcinoma and condyloma lata. And this is the Bartholin cyst. Bartholin cyst is basically present in the labia majora. So it's a cyst in the labia majora at the junction between the upper 2/3 and lower 1/3. Upper 2/3 and lower 1/3. So it is a cyst in the labia majora. Bartholin's gland is basically a compound racemose gland, and it is most commonly infected with gonococci. Okay. Now when you see a cyst, you usually do marsupialization of the cyst. If it's an abscess, then you do IND. Okay. So this is not a vulval cyst. You can say it's a cyst, vulval cyst. It's a cyst on the labia majora. Okay. And now this is an anterior vaginal wall cyst. In clear palpation, this is an anterior vaginal wall cyst, and this is Gartner's cyst. Gartner's cyst. So what is Gartner's cyst? It is a cyst arising from the Wolffian duct. Remnants of Wolffian duct is also present in the female, and it's a cyst arising from the Wolffian duct. So clearly when this is shown, now this is a vulval hematoma. Which of the following is least likely cause of secondary amenorrhea? See, Coleman, Turner mosaic, yes, can cause secondary amenorrhea. Fragile X mutation, yes. Sheehan syndrome is postpartum pituitary necrosis, yes. But think of Coleman syndrome. Coleman syndrome is hypothalamic failure. Coleman syndrome is hypothalamic failure, and Coleman syndrome is a case of primary amenorrhea. Okay, so it's a very simple and a very easy question. Okay, which of the following is true about human transplacental cytomegalovirus infection? Okay, so now regarding cytomegalovirus, we need to understand cytomegalovirus. Why this question is basically asked? That is because cytomegalovirus is the most common congenital infection. Okay, now cytomegalovirus infection, I am going to list the salient points. Now this is the most common congenital infection. Not only that, it is the most common cause of sensory neural hearing loss in babies, in fetuses, or and say in babies. Okay, now cytomegalovirus is basically herpes virus. It is human herpes virus 5. Is that understandable? Okay, now when we take the incidence of cytomegalovirus in our country, please understand that in developed countries, 50% of the people are seropositive. It means 50% of the people are affected and 50% not affected. But in a country like India, it is said it almost 90 to 95% of people, 90 to 95% of people are seropositive. So what do we mean? You check CMV IgG for you and me, or we will be positive. That means we will be immune. Okay, so we all would have had cytomegalovirus infection in our childhood. Okay, a cytomegalovirus infection, because it's a herpes infection, a reactivation is possible. Okay, now when the baby will be affected, now what you need to understand is, now say this is mother, this is the fetus. Okay, now if it's a primary infection, mother is getting cytomegalovirus infection for the first time in pregnancy, then the chance of baby getting infected is 40%. Now this is a very, very important number regarding cytomegalovirus you should understand. If it's a recurrent infection or it's a reactivation, because it's a herpes virus, reactivation is very common. You all know that they are all latent, they can remain latent and get reactivated anytime. The chance of infection to the baby, the chance of the baby getting affected is only 1 to 2%. So please remember these percentages. So is that understandable? Okay. Okay. Now, this cytomegalovirus infection, say 40%. Now we are not worried about this reactivation because the chance of the baby getting affected is very low. So we will focus on this primary infection where 40% chance of the baby getting affected. Okay. So we have 40% CMV infected fetuses. Please make a note of this. 40% CMV infected fetuses with primary infection. Okay. Now of these 40%, remember that 10 to 20% only will be symptomatic at birth. Only 10 to 20% will be symptomatic at birth. What all symptoms can occur? It can be very severe cytomegalovirus infection which can cause a stillbirth, and it can cause chorioretinitis. I already told you it is the most common cause of sensorineural hearing loss. We'll draw ears. Sensorineural hearing loss. Mental retardation, microcephaly, mental retardation, severe growth restriction in the baby, hepatosplenomegaly, I'll simply write HS, purpura, thrombocytopenia. Of course, I've already written. So 10 to 20% of these babies will have these manifestations. So that means remaining 80 to 90% of the babies are normal at birth or asymptomatic. Now, is that a very happy news? Asymptomatic at birth. But please remember that if they are asymptomatic at birth, still of these people, some again 10 to 20%. So many percentages, but it's very simple to remember, will have long-term sequelae. Will have long-term sequelae. Is that understandable? Okay. So even if the babies are asymptomatic at birth, 10 to 20% of them can have long-term sequelae, like they can have sensorineural hearing loss later in life. So that is the take-home message here. Okay. And another important point regarding cytomegalovirus that I want to tell you is, this cytomegalovirus characteristically in the brain, it causes periventricular calcifications. Periventricular calcification. Whereas if you take toxoplasmosis, the calcifications are scattered throughout the brain matter. Now this is periventricular calcifications. So if a fetal infection is established, like if we find in the amniotic fluid cytomegalovirus DNA, which is present 6 weeks after the seroconversion in the mother, definitely we can offer her a medical termination of pregnancy. Okay, so that is about more details of cytomegalovirus. Every single point we have, how to test the mother, how to test the fetus, whether it is infected or not. Okay, we have it in the app and you can go and watch it. It's a 30-40 minutes topic and you can watch step by step. So the take home message is, the baby gets more infected if it's a primary infection and the chance of infectivity is 40%. Out of the 40% CME infected fetuses, only 10 to 20% are symptomatic at birth and remaining 80 to 90% are asymptomatic. But then 10 to 20% of the asymptomatic fetuses can have long-term sequelae. Let's go into the questions. Hearing loss can appear in asymptomatic, later in life in asymptomatic babies. Yes, now this is a very, very important statement. 30 to 40% babies with a CMV are asymptomatic at birth. No, how many percent of babies are asymptomatic at birth? It's 80 to 90% is asymptomatic at birth. So this statement is wrong. The classical triad of hearing loss, hypoplastic enamel, intracranial calcification is seen in 30 to 40%. No. Whatever it is, it's only 10 to 20% which are symptomatic. So this statement is also wrong. Babies born to mothers who have IgG CMV antibodies are immune to transplacental spread. No, I told you, even with maternal IgG positivity, if there is a reactivation, like any herpes virus, if there is a reactivation, then there is 1 to 2% chance of the baby getting affected. Okay, so here the correct statement is, hearing loss can appear later in life in asymptomatic babies. Is that okay? Okay. So thank you all for your patient listening.